start.
सर कोरोना वालों को बोल दीजिए प्लीज.
Oh yes.
Please start live streaming.
Oh yes.
Yes, I'm starting it live.
So
We-
you let us know, then we will start.
Who is on behalf of Corona? Nilesh is not there.
Sir, I will run everything.
No issue. But just to have information, who is from Corona?
I'm Abhimanyu.
Abhimanyu. Okay.
Yes, technical person is.
Oh yes.
I'm
Oh
a
yes.
technical person.
Yes.
I have just started the live session, so it is already live. Sir.
Oh yes.
Do you want to start the program?
Oh yes. We can start.
Abhimanyu, you want to start?
Yes. No, actually, ma'am,
Okay.
I'm
I'll
just
do-
technical. Yeah.
Okay. Namaskar, everyone. On behalf of Happy Learning Masterclass, session 149 and Corona Remedies, I welcome all of you. I am Dr. Asha Jain, past president, Raipur Obstetric Gynec Society, your MOC, along with Dr. Suman Sinha, who's the president of Ranchi Society. She'll not be joining us today, and Dr. Prerna Kishan, who's a consultant gynecologist and infertility specialist, endoscopic surgeon, and a master in cosmetic gynecology from Tinsukia. So, our coordinators today are Dr. B. Kalpana, Dr. Jyoti Banglowala, and Dr. Deepti Goswami. Dr. B. Kalpana is from Madurai Obstetric Gynec Society. Dr. Jyoti is past secretary from Indore Obstetric Gynec Society, and Dr. Deepti Goswami is the secretary, Guwahati Obstetric Gynec Society. Welcome, all of you, and we pray to the divine for blessings. With the blessings of seniors, I would like to also invite our conveners, Dr. Nilakshi Fukan and Dr. Sneha Guyar, whom we will introduce shortly. And I would like to welcome Dr. MC Patel, sir, who was the past VP of Foxy, the program director of this Happy Masterclass. Welcome, sir, for your welcome address of this program.
So, thank you, Dr. Asha. It gives me immense pleasure to welcome you all for our 149th episode of Happy Learning Masterclass in a row. And today's joining society of all the societies of Assam, Barpeta, Dibrugarh, Guwahati, Jorhat, Nagaon, Nalbari, Silchar, and Tejpur. I welcome Dr. Aloka Goswami Madam, who has kindly consented to be chief guest to bless us, and she is going to join very shortly. I also welcome Dr. Gokul Das. He has some meeting and he will join little late. He had a phone call to me. I also welcome Dr. Rina Datta Madam, who has kindly consented to be guest of honor to bless the webinar. I also welcome two learned speakers, Dr. Shikha Bathwal from Guwahati. She is going to talk very interesting topic, nutraceuticals in male infertility. And I also welcome Dr. Irene Saloy, again from Guwahati, and she is going to talk about endometrial receptivity. I also welcome two learned moderators who are going to discuss very interesting case scenario during panel discussion, Dr. Pratibha Prasari Madam and Dr. Isha Goyal Madam. I also welcome expert comments during panel by Dr. Sneha Buyar from Yavatmal, Dr. Rekha Rajendra Kumar from Bengaluru, and Dr. Bharati Rajsekhar from Hassan. I also welcome all the learned panelists who have kindly consented to join this webinar as a panelist. Dr. Juri from Guwahati, Dr. Subhendu from Guwahati, Dr. Sweta Balsani from Guwahati, Dr. Deepak Sharma from Guwahati, Dr. Arun Barua from Guwahati, Dr. Kanchan Murarka from Guwahati, Dr. Mukesh Pogla from Dibrugarh, Dr. Devanjana Datta Madam from Silchar, Dr. Sunita Gogoi Madam from Tejpur. I also welcome all the chairpersons who have kindly consented to chair respective session. Dr. S.I. Bora sir from Guwahati, Dr. Manjima Ganguly Madam from Guwahati, Dr. Pranay Phukon from Dibrugarh, Nilakshi Phukon from Guwahati, Jasmina Sharma Madam from Dibrugarh, Amol Kumar Phukon from Jorhat, and Dr. Prabhanika Mahanta Madam from Jorhat, Dr. Hemkanta Dev Sharma sir from Barpeta. Of course, just now he is at Jorhat. Dr. Pankaj Barua from Jorhat. I also welcome convener Nilakshi Phukan and Dr. Sneha Buyar. And I put it in record all the efforts and help given to us for this webinar by Dr. Nilakshi Phukan. I welcome Nilakshi and thanks for everything. I also welcome two coordinator, Dr. Dipti Goswami, Secretary of Guwahati OBGYN Society. I again put it on record for all the efforts and help given by Dipti Goswami also for this webinar. I also welcome Dr. B. Kalpana from Madurai and Dr. Jyoti Banglowala from Indore. They both are working as coordinator in this series since long. I also welcome Master of Ceremony Prerna Keshan from Tinsukia, Dr. Asha Jain from Raipur, and Suman Sinha from Ranchi. Of course, Suman is not going to join due to some personal reason. So with this, I welcome all the delegates who have joined this webinar and all the president and secretary of joining society. In era of COVID-19, where physical meetings were not possible, we started this series to discuss focused topic and to meet our Foxian friends to say hello. And with continuity, with blessings of seniors, support and help from friends, we have continued this series even after COVID. And today is 149th episode of this series. So welcoming you all without wasting much of your time. I will hand over mic to Asha Jain for further proceeding. But today we have chosen topic related to infertility, and it is again a very interesting topic we are going to discuss. Thank you very much.
Thank you, MC sir, for that welcome address. And I would like to invite Dr. Nilakshi Phukan Kumar. Sorry, Prerna.
Thank you, ma'am. Thank you, sir. Yes.
Prerna, please go ahead.
Thank you, ma'am. Yes. Thank you, sir, for that warm welcome towards everybody. And we are indeed honored with this wonderful scientific session that is going to be held today. And what a star-studded evening it is. And I would like to welcome our first convener for this meeting, Dr. Nilakshi Phukan Madam. She is the President, Guwahati OBGYN Society, and a very dear fraternity from our area, from Northeastern region, and consultant Downtown Hospital, Dr. K.C. Das Nursing Home, Guwahati, visiting consultant at Pratiksha Hospital, Guwahati, Director, Gynaec Center, President, Guwahati OBGYN Society, former Secretary, IMS Guwahati Chapter, Founder, President, Guwahati Menopause Society, and so many more credits to ma'am. Welcome, ma'am, to this podium, and the stage is all yours, ma'am. We would like to hear a few words of wisdom from your end. Dr. Nilakshi, ma'am.
Thank you, Prerna, for the kind words. Good evening, Patel sir. Good evening, Dr. Sneha, Dr. Jyoti, and everyone present in this forum. I think it will be a wonderful presentation. I think it was a request from sir, and we were supposed to do it in the month of June. So for something or other, because we had too many programs in June, we could not make it. We are really very sorry for that, sir. So this time we have planned to go for the infertility bag, where we have all the speakers, like to deal with the male infertility and the endometrial receptivity, and the most common and widely practiced even by the gynecologist about the ovulation index. And what we thought that it will be of help to all the participants of this webinar. Thank you. I think without delay, we should proceed for the scientific session. Thank you, Prerna.
Thank you,
Thank
Thank you,
ma'am.
madam, for
Thank you,
Thanks a lot.
Nilakshi, for all the help you have extended to us for this webinar. Thank you. Thank you very much.
Dr. Sneha is not here, so we will have her say something once she joins. And I would like to invite our chief guest, Dr. Aloka Goswami. She is an MBBS MS obstetric gynae. She has an experience of 64 years in these fields. She completed MBBS from University of Guwahati in 1958, MS obstetric gynae from University of Lucknow in 1964. She's a member of Medical Council of India. Some of the services provided by the doctor are amenorrhea treatment, dysmenorrhea treatment, fertilization in vitro, embryo transfer, fertility conserving procedures, and fertilization, etc. So welcome, ma'am. We would like to have your blessings for this program.
Has Madam joined? I don't see.
Only Reena Datta madam joined.
Okay,
Asha.
no issue. Then we can proceed. Whenever she joins, we will have
Yes.
blessing at that time.
whenever
Madam is
ma'am
not
joins,
probably.
ma'am will be.
Prerna, by the
she-
already joined Korisu boli koisile mo. I don't know whether she called me and she said, yes, I am able to join. That's why.
Yes, I had also phone call to her. She told me.
Dr. Prerna, would you introduce Gokul sir?
Yes, ma'am. Gokul sir has also not joined, I
No,
suppose.
he will join little late. He has some meeting with your
Okay.
CM.
Oh,
And
Would
as
you
per
read
his-
his CV and we can
yes,
take the
yes,
program
ma'am.
forward?
Our chief guest for today, as a teacher of teachers, Dr. Gokul Chandra Das sir. He's an MD, FICMCH, FICOG, FIOG, and as a OSD Srimanta Shankar Academy of Health and Sciences, Guwahati, Assam 2020, founder, professor and HOD of TRIMS, Naharlagun, Arunachal Pradesh 1820, professor and HOD of OBGYN Society, Guwahati Medical College in 2012-15, officer in charge, Fields Unit, Guwahati, National Institute of Research in Human Reproduction, ICMR, Mumbai, 2012-17. Vice President, Federation of ONG Societies of India, 2014. Member, Governing Body, ICOG, 2014-16. President, Guwahati OBGYN Society, 2012-14. Sir has been the president of the Association of ONG Societies of Assam and Northeast, and he has delivered immense number of guest lectures and as oration or panelist in national and international conferences, and has published various chapters in Foxy publications and articles in national and international journals. We are really very honored to have Sir amongst us today, to have his blessings. If Sir joins within a while, then we will ask him to speak for the August gathering here. We now move on to our guest of honor. Ma'am, would you like?
I'll introduce her, Prerna.
Yes.
So our guest of honor today is Dr. Reena Datta ma'am. She is an ex-professor and HOD gynae, AMC Dibrugarh. She is a retired professor and HOD, Department of Obstetrics and Gynae, Assam Medical College and Hospital, Dibrugarh, presently consultant gynecologist at Dibrugarh, past secretary of Dibrugarh Obstetric Gynec Society, past president of Dibrugarh Gynec Society, present president of Dibrugarh branch of IMS, life member of Foxy, ISOPAP, IAG, PCOS, ESAR, Endometriosis Society, and IMA. She has published a few articles in national and international journals and delivered lectures in different regional and national level conferences very regularly. So, Reena ma'am, we would be honored to have your blessings for this program.
Good afternoon, everybody. It is really my great pleasure to be here today. And I offer my sincere thanks to Patel, Dr. Patel. He called me up and to be present here. And I really feel myself lucky to be with you this evening. and we can have a very fruitful discussion on infertility, and we'll have a very good time, and we're very happy to see each other, and really happy to see Aloka Baidu. Maybe she will be joining. She was my teacher in my postgraduate days in Guwahati Medical College. So thank you very much. And see you again in future. And now we will enjoy the program in the subsequent.
Thank you, Reena Madam, for sparing time to bless us. Of course, you are always with us in any of our academic activity. Thank you, Madam.
Reena, you'll give the vote of thanks.
Yes. So every good thing has to come to a session which we call the vote of thanks, and it's exemplary that we extend our gratitude to each and every delegate and faculty who has joined today for this inaugural ceremony. At the very outset, I would like to thank our program director, Dr. MC Patel sir, for giving us this opportunity to come along with everybody in this CME, and our conveners for the evening, Dr. Nilakshi Fukan madam and Dr. Sneha Bhuyar madam. Our chief guest, Dr. Gokul Das sir and Dr. Aloka Goswami Baidu, and our guest of honor, Dr. Reena Datta Ahmed, and everyone, all of you who has joined in this webinar to make it a grand success. Thank you, and I wish the scientific session goes well beyond all limits. Thank you.
To Corona remedies also to make this program feasible.
Yes, ma'am.
Wait, something went wrong.
Yes, now you are audible.
So
We can hand the.
with this, I hand over the session to Dr. Jyoti Bankawala.
Ma'am's internet is unstable, I suppose.
Dr.
I would
Jyoti
like to
Bankawala and Dr. Kalpana.
Thank you. Thank you very much, ma'am. So I am very thankful to all the societies who have joined, and to all the seniors, faculties, and all the guest of honor and chief guest, and especially Dr. Prerna Keshe and Dr. Deepti Goswami. And first of all, I want to thank Dr. MC Patel sir for giving us all this opportunity, and the Barpeta, Dibrugarh, Guwahati, Jorhat, Nagaon, Nalbari, Silchar, and Tejpur societies, from where all the delegates have joined and all the seniors have joined. And our first session today is on the male infertility with the for this, I am inviting as a chairperson, Dr. Shahidul Islam Borha sir. He is Associate Professor in Obstetric and Gynae Department, Guwahati Medical College. He is the Vice President, Guwahati Obs and Gynae Society, and ex-General Secretary, Guwahati Obs and Gynae Society. He has presented research paper in the AICOG Agra, Ahmedabad, and Bhubaneswar, and delivered the guest lecture in the AICOG Bhubaneswar. He chaired scientific session in various national and international conferences, and he had 14 original scientific research paper publication in all the national and international index journals. He is an undergraduate and postgraduate teacher and university examiner under undergraduate and postgraduate students. His area of special interest is gynecological endoscopy, and he is trained in the gynecological endoscopic surgery at Mumbai. He is having the vast experience of 31 years in teaching, and as a registrar, assistant professor, and associate professor at different medical colleges of Assam. We welcome you, sir. Our next chairperson is Dr. Manjima Baish Ganguly madam. She is the presently vice president of the Guwahati Obs Gynae Society and former IMA Dispur president and general secretary, member of National Mission Pink Health IMA and life member of IMA. She is the life member Indian Menopause Society and presented many papers and chaired many sessions at international and regional conferences. We welcome you, Manjima Vashi madam. Our third chairperson, Dr. Pranay Fukan sir. He is a professor and HOD of Obs Gynae in the Lakhimpur Medical College, Assam, and teacher of undergraduate and postgraduate for last 32 years. He has been the university examiner of MBBS, MS, and PhD, and ICOG visiting professor in the 2015 to 16. He is he is awarded with the AFOG Young Gynecologist Award in the 2002 and president of Dibrugarh Obs-Gynae Society since 2022 to present. He is the honorary secretary Dibrugarh Menopause Society since 2021, and he is having more than 25 original papers published in the national and the international index journal. His area of special interest is infertility and endometriosis, and he has trained in Boston, USA in the infertility. He has contributed many chapters in postgraduate books in the gynecology and pediatrics and chief editor of Handbook of Infertility for Practitioner, which is published in 2021. He has been the organizing secretary and chairperson of many OBS and gynae conferences and seminars in his area. He is resource person in radio and television program on health. We welcome you, sir. I request you all to come on the dais, and I request Shaidul sir to introduce our speaker, Dr. Shikha Batwal, and I request Dr. Manjima ma'am to open the topic by saying a few words about that, and then to conclude the topic. Shaidul sir. Yes.
Ladies and gentlemen, distinguished guests and esteemed participants, and our chief guest, Dr. Oloka ma'am, our chief guest, Dr. Gokul Das sir, and guest of honor, Dr. Rina ma'am. Good evening to all of you. It is my honor to welcome you to session 1 of this highly anticipated webinar on the topic of nutraceuticals in male infertility. As one of the chairperson of this event, I stand before you today to great enthusiasm and gratitude for your presence. And male infertility, all of you, is a complex issue that affects millions of couples around the world. It poses significant challenges and emotional distress to those aspiring to start a family. However, thanks to advancement in medical research and the emergence of nutraceuticals, we now have promising avenues to explore in addressing this pressing concern. Nutraceuticals, as many of you know, are naturally derived compounds or substances that provide health benefits beyond basic nutrition. Now, I would like to invite my co-chairperson, Dr. Manjima Ganguly, to introduce our speaker, Dr. Shikha Batwal. Over to Dr. Manjima.
Thank you, Dr. Shaidul. I'd like to introduce Dr. Shikha Batwal. She's an MD from AIIMS Delhi, gold medalist, FNB in reproductive medicine. She's an IVF consultant in Pratiksha Hospital, Guwahati. She's member of ISAR IFS FOXY. She has presented many papers in national and state conferences. She has 9 publications to her credit, and she has been awarded the Roberts G. Edwards Prize Paper Award for being the best paper published in Reproductive Biomed Online Journal in 2019. And it was also presented in the Best of RBMO session in COGI 2020. She is also the winner of ISAR ASRM National Quiz for Clinicians 2018. And she's the co-author of the paper awarded first runner-up of FOXY Korean Award in senior category for the year 2014. So I'd like to invite Dr. Shikha to present her topic on very interesting topic and a new topic on nutraceuticals in male infertility. Dr. Shikha.
Yes. Dr. Shikha, you may share your screen.
Yes, ma'am. Yes, ma'am. Just a minute, ma'am.
Your screen is visible. Yeah.
Yes.
Thank you, ma'am, for your kind words. A very good evening to all. Firstly, I would like to thank Dr. Nilakshi Fukan, ma'am, Dr. Deepti Goswami, ma'am, and Dr. MC Patel, sir, for giving me this wonderful opportunity to talk in this platform. So my topic is nutraceuticals in male infertility. Infertility affects nearly 15% of couples. Around 25% of cases are exclusively caused by male factor. Overall, 30 to 40% of infertility cases have direct contributions from male factor. Over the past 50 years, there has been a steady decrease in the sperm quality. Male infertility is commonly caused by alterations in either semen ejection, absence or low level of sperm, or sperm morphology and motility alterations. So in this diagram, we can see that there are various causes of male infertility, ranging from the local causes like varicocele, undescended testis infections, sexual factors, systemic diseases. But the majority chunk, the large portion, around 35%, is caused by the unexplained infertility. This can be further subdivided into two, depending on the semen analysis report. If there is no attributed cause to the male infertility and the semen analysis report is showing abnormal, showing oligoasthenoteratozoospermia, that comes under the category of idiopathic male infertility, which is around 30 to 50% of cases. And if the semen analysis report is normal, then it is unexplained male infertility, around 15% of cases. So oxidative stress has been established as a significant mediator in many known cases of male infertility. In around 30 to 80% of idiopathic male infertility cases, it is oxidative stress is associated. And this condition is termed as male oxidative stress infertility. So nowadays, antioxidants are being increasingly used to improve the sperm function by controlling oxidative stress. However, there remains no consensus on the efficacy, indications, dosage, or the length of treatment. So ROS, which is reactive oxygen species, can damage sperm DNA, membranes, proteins, can lead to impaired motility, cytoskeletal damage, disruption of the membrane fluidity, and even sperm apoptosis. ROS are just oxygen-containing compounds that have one or more unpaired electrons, free radicals, as well as non-radical oxygen compounds. Most common free radical is superoxide radical. And ozone and hydrogen peroxide are non-radical ROS. So normally in the human body, a small amount of ROS is naturally physiologically produced. The prevalent sources are leukocytes and abnormal sperm. Leukocytes, mainly macrophages and neutrophils, they produce ROS as a part of defense against the pathogens. The abnormal sperms, they relatively have large amount of cytoplasm with increased NADP oxidase enzyme in the sperm membrane, thus leading to increased production of ROS. A physiological overproduction of ROS also occurs during sperm hyperactivation, capacitation, and fertilization. In fact, a small amount of ROS is very essential for these processes to occur. So whenever the generation of ROS surpasses the sperm's capacity to counteract it, oxidative stress occurs. Sperms are particularly more vulnerable to oxidative damage owing to their abundance of polyunsaturated fatty acids. So in this diagram, we can see that the sperm plasma membrane contains PUFA. This is acted upon by the enzyme NADPH oxidase, which produces ROS. And when there is increase in the enzyme level, there is furthermore ROS generation leading to lipid peroxidation. Also, there is naturally when sperm maturation occurs, there is a reduction in the cytoplasm, which contains essential enzymes, thus limiting its ability to counteract the ROS. So this diagram shows the various causes of male infertility, which eventually will produce ROS leading to oxidative stress, be it drugs, varicocele, smoking, pollution, cancer, infections, everything. So they will all lead to oxidative stress, which further leads to protein damage, lipid peroxidation, biomembrane damage, and DNA damage. So the term nutraceuticals, this was first coined in the year 1989 by Dr. Stephen D. Fellis from Nutrition and Pharmaceutical. So it is any substance that is a food or a part of food that provides medical or health benefits, including the prevention and treatment of disease. So in the context of male infertility, this is nothing but antioxidants and other dietary supplements, which we give to improve the semen analysis report. So antioxidants, they are the molecules that scavenge the free radicals and prevent cell damage. They can be categorized as enzymatic and non-enzymatic. Enzymatic antioxidants prevent the reaction of ROS with bodily substance and thus prevent the cellular damage. The examples are superoxide dismutase, catalase, glutathione peroxidase. Non-enzymatic antioxidants, they include synthetic or dietary antioxidants, which modify or deactivate the ROS. So now in the subsequent slides, I'll be dealing with some of the antioxidants one by one. So carnitine. Carnitine is an antioxidant with two important isomers being called as L-carnitine and its active form L-acetyl-carnitine. It is found in epididymis, seminal plasma, and in spermatozoa. It protects the phospholipids of the mitochondrial membrane by preventing fatty acid oxidation. And carnitines assist sperm metabolism by positively affecting the sperm concentration, motility, and maturation. The common sources are red meat, fish, poultry, and dairy. Usual dose is around 2 grams per day. Dose above 3 grams per day can give rise to GI side effects. Carotenoids. V-carotene, a provitamin A, can directly scavenge ROS. Other carotenoids found in food are lycopene, lutein, and zeaxanthin. Lycopene is thought to have greatest ROS quenching rate of all the antioxidants. Infertile men have less lycopene levels in seminal plasma than fertile men. Lycopene also protects isolated lipid membranes from peroxidation. The common sources are green leafy vegetables, fruits, and some vegetable oils. Coenzyme Q10. It is a fat-soluble antioxidant synthesized endogenously. It can easily cross the blood-testis barrier along with carnitine, and it is an essential cofactor of the mitochondrial energy metabolism. The active form of coenzyme Q10 is ubiquinol, which is also its reduced form. Ubiquinol inhibits the protein and DNA oxidation and lipid peroxidation. It also improves antioxidant enzyme activity. The common sources are meat, fish, nuts, and some oils, and the optimal dose is around 200 to 300 milligrams per day. Cysteine. N-acetylcysteine is a precursor of the amino acid cysteine and a scavenger of ROS. Cysteine plays an important role in glutathione synthesis. Glutathione becomes depleted whenever there is oxidative stress, and this can be reversed by N-acetylcysteine supplementation. NAC is less toxic and less susceptible to oxidation compared to cysteine itself. Arginine is a semi-essential amino acid required for normal spermatogenesis. It has a role in inflammatory response as a free radical scavenger. Common sources are meat products, dairy, nuts, and seeds. Arginine is contraindicated for people with a history of genital or oral herpes, asthma, or cancer. Folate. Folate is a micronutrient important for the synthesis of DNA, transfer RNA, and the amino acids cysteine and methionine. Folic acid, the synthetic form, scavenges free radicals and it inhibits lipid peroxidation. The sources are green leafy vegetables, liver, bread, yeast, and fruits. Folic acid dose of more than 5 milligrams per day can cause abdominal cramps, diarrhea, and rash. Higher doses can even cause altered sleep patterns, irritability, confusion, and seizures. Zinc. Zinc is an important cofactor in DNA transcription and protein synthesis, and it has got extensive antioxidant properties. It has an important role in testis development, sperm physiological function, and decrease of zinc in the seminal plasma is associated with decreased sperm quality. The common source is meat products, wheat, and seeds. Selenium. Magnesium and selenium are different from other antioxidants in that they increase the activity of antioxidant enzyme, glutathione peroxidase, and they do not act directly. Selenium is essential for normal spermatogenesis. The main sources are fish, meat products, dairy, and soil. Chronically high selenium intake can lead to GI symptoms, fatigue, hair loss, joint pain, and nail problems. Vitamins. Vitamin E, bioactive form alpha tocopherol, has a principal role by being the first defense against oxidant-induced membrane injury. It is found in vegetable oil, and there is a given upper daily limit. Vitamin C. Vitamin C is able to diminish the DNA damage directly by scavenging free radicals and also reduces the formation of lipid hydroperoxides. Some studies have reported a possible synergistic effect of vitamin C and E. Myoinositol, it is the highest concentration in the genital tract is within the seminiferous tubules and it is produced by Sertoli cells. It is a precursor for the phosphatidyl-inositol signaling pathway, and it is involved in the regulation of sperm motility, capacitation, and acrosome reaction. Common sources are corn, bean, fruits, and nuts. Vitamin D. It has been suggested that 1,25-dihydroxyvitamin D has antioxidant activity, mainly by inducing the antioxidant enzyme superoxide dismutase. However, its role in male infertility is not well studied. So this diagram we can see, different antioxidants act on different parts of the sperm, like L-carnitine, coenzyme Q10. It acts on the sperm Mitochondria increases the ATP production, thus increasing the motility. L-arginine acts on the vitality. Various vitamins, they act on the sperm concentration. Lycopene reduces the DNA damage and lipid peroxidation. Similarly, folic acid also reduces the DNA damage. So there are so many antioxidants, but what is the rationale for antioxidant use? So we have seen in the previous slides that a low production of ROS is physiological and is required for adequate sperm function by helping capacitation, maturation, and hyperactivation. And whatever be the cause of male infertility, most of them lead to production of oxidative stress, thus causing sperm DNA damage and reducing the pregnancy and live birth rate. Thus, supplementing exogenous antioxidant improves these outcomes. There is a fine balance between preventing oxidative stress by antioxidants, removing excessive ROS, and maintaining a small amount of ROS for their physiological effect on the sperm function. It has been documented that as a rebound effect of overdose of antioxidants, reductive stress can happen. This has been seen with vitamin E also. Therefore, high doses of antioxidants should better be avoided. Cost effectiveness. Antioxidants, by improving sperm quality, may increase the chance of natural conception. So we have seen so many antioxidants, but what is the evidence for its use? So many trials with mono or poly combination of antioxidants are there. However, they show conflicting results. The major limitation of the studies done on the role of antioxidants are lack of standardization. Majority of the studies are not placebo-controlled. Most study reports changes in the sperm parameters only and not fertility and live birth rate. And most of the studies use different combination, different doses of antioxidant for different duration of time, thus making the comparison of results and comparison of different antioxidants very difficult. So the first meta-analysis was done in Cochrane Review 2011. It concluded that there is low level of evidence supporting antioxidant therapy in infertile males to increase the pregnancy and live birth rate. Mazoub and Agarwal in 2018 conducted a systematic review on antioxidant treatment in infertile men. They concluded that antioxidants have a positive effect on male infertility, including improvement of semen parameters, an advanced sperm function test, pregnancy outcome, and live birth rate. So the latest Cochrane review of 2022, it included 90 studies with more than 10,000 fertile men. They had 20 different oral antioxidants. The evidence was of low to very low quality, and only out of 90, only 20 studies reported clinical pregnancy. And out of these, only 12 reported on live birth. So they concluded that antioxidants may lead to increased live birth rate with the odds ratio of 1.43. However, when studies at high risk of bias were removed from the analysis, there was no evidence of increased live birth. So we can see in this table of Cochrane review that live birth rate and clinical pregnancy rate both are increasing. However, the evidence is of very low to low grade of evidence. Miscarriage rate is similar compared to the placebo group, and GI side effects are mildly increased. ASRM guideline of male infertility 2020, they suggest that clinicians should counsel patients that the benefits of supplements like antioxidants and vitamins are of questionable clinical utility in treating male infertility. Existing data are inadequate to provide recommendation for specific agents to be used for this purpose. So coming to the SWOT analysis of this topic. So the strengths of the topic on the studies of nutraceuticals is that there is extensive interest in the use of antioxidants for the treatment of male infertility. And it has been associated with improvement in semen parameters and advanced test of sperm function. Minimum side effects are there. The current evidence suggests that it is effective in idiopathic and unexplained male infertility. What are the weaknesses? So there are contradictory results with regards to the impact of antioxidant treatment on reproductive outcome. Several studies did not adjust for confounding factors when examining the effect of antioxidant treatment. The opportunities, since they are an easy and cost-effective alternative for infertile couples who want to avoid ART. And recent efforts propose tailoring the treatment towards patients with evidence of oxidative stress. That is, we should ideally measure the oxidative stress and accordingly give the treatment. and recent proteomic studies offered a better understanding of the molecular pathways involved with antioxidant supplementation. What are the threats? The exaggerated use of antioxidants may cause reductive stress. And the evidence, whatever is available, is presently of low quality. Sometimes this therapy may unnecessarily delay treatment in some cases like varicocele, severe male factor infertility, and couples of advanced stage. So what is the future direction? Since we have seen that some amount of ROS is physiologically produced in the body, so it is crucial to study the physiological and pathophysiological mechanism of ROS in male reproductive tract and its relevance for sperm production and conception. Also, standardization of oxidative stress measurement must also be implemented. Till date, there are no dose-response studies in humans to pinpoint the optimum antioxidant dosages to provide improvement in semen quality. That needs to be conducted. Also, personalized or adjusted prescription of oral antioxidants can enhance the efficacy without promoting excessive dosage and deleterious health effects, including reductive stress. So how do we measure the oxidative stress markers? What are the markers? So one can directly, levels of seminal ROS can be measured. Several endogenous antioxidants like total antioxidant capacity assays there, superoxide dismutase, catalase, and glutathione. Also markers of lipid peroxidation like MDA, oxidative DNA damage. This is the oxidation reduction potential. Also sperm DNA fragmentation assay, it is an indirect but very important marker for measuring the oxidative stress indirectly. So here we can see like basic semen analysis can be done. Along with that, in the future, once it is standardized, one should evaluate the oxidative stress by measuring the oxidation reduction potential using the MI-OXIS system. So the MI-OXIS system is a system to check the overall redox potential of the seminal fluid to direct the treatment and to evaluate the oxidative and reductive stress. So if the oxidative stress is present, then we have to check why it is present. If there is infection, we have to treat that. Lifestyle changes, varicocele treatment. If there is no cause, that is, if it is male oxidative stress infertility, one can supplement antioxidant for 3 months. And after 3 months, one should retest for the oxidative stress. So what is the take-home message? At present, there is no universally accepted antioxidants. Scientific principles such as that combination approach using antioxidant with different modes of action which would act synergistically and give better results. And the combination should be such that antioxidants which cross the blood-testis barrier and blood epididymal barrier should be recommended. The formulation should be well balanced with lipid-soluble as well as water-soluble antioxidants. Duration of treatment should be at least 3 months in most cases. Future placebo-controlled studies with clinically important endpoints like sperm DNA damage, live birth needs to be conducted. Larger trials with high-quality controls and randomization must be performed. However, at present, antioxidants are generally inexpensive and carry minimal side effects. Therefore, a combination antioxidant therapy presently appears to be a reasonable treatment option for optimizing the male fertility potential. Thank you very much.
Thank you, Dr. Shikha Batwal, for your very informative presentation on the nutraceuticals on male infertility.
Thank you, sir.
Now the topic is open for discussion.
Sir, may I request Dr. Pranay Phukan, sir, to give some expert comment as a chairperson?
Shikha, please stop sharing.
Yes, ma'am.
Dr. Pranay Phukan, sir.
He's here.
Pranay Phukan, sir. He's here. I think he's muted actually.
Jyoti, I think somebody else can sum up.
Okay. Manjima madam can sum up. Manjima ma'am. Manjima madam, please unmute yourself.
Yeah. Thank you, everyone, especially Dr. Shikha Batwal, for your very informative lectures on nutraceuticals in male infertility. As you have correctly mentioned, all the different types of nutraceuticals which are important for the function and for the development of the sperm. And you also mentioned that we must not put a lot of stress on them, because sometimes giving excessive nutraceuticals like antioxidants may cause some reverse side effects. On the whole, it was very informative, and I thank you very much for your speech. So thank you.
madam.
Yes.
Yeah, it was really a wonderful talk, which is really a debatable topic too. So now moving on to the second interesting topic, endometrial receptivity. So we have chairperson who is also the convener of this program, taken so much effort to design this program, Dr. Nilakshi Fukan Kumar ma'am, who is a consultant, Downtown Hospital, KC Das Nursing Home, Guwahati, visiting consultant, Pratiksha Hospital, Director, Gynec Center, President, Guwahati OG Society, past Secretary of IMS Guwahati Chapter, Founder President of Guwahati Menopause Society, Joint Secretary AIC OG Guwahati, invited speaker in many national, international conferences. Welcome, ma'am. And our next chairperson is Dr. Jasmine Sharma, ma'am, who has been trained in infertility and laparoscopy. Madam is the life member of various organizations, IMA, FOGSI, Indian Menopausal Society, INTV, and Madam is the secretary of the Brugar UG Society. Welcome, ma'am. This chairperson is Amal Kumar Fukan, sir, who is a senior gynecologist, past Secretary General, Jharkhand UG Society, and trained in laparoscopic surgery, and director of Sanjeevani Hospital, Assam. Welcome, sir. Over to you, chairpersons. Nilakshi ma'am, you can introduce the speaker. Jasmine ma'am, you can give an intro about the topic, and Amal Kumar sir, you can conclude after the talk. Nilakshi, Fukan.
Thank you, Asha, Dr. Asha. So I welcome you to the second talk of this session. This is none other than, hello, am I audible?
Yes, ma'am.
Yes, ma'am.
Our speaker is Dr. Irene Sandler. Can I have her CV? Because though I know her personally, so I think it's the formality to have her. Yeah, she is a young gynecologist from Guwahati, and she is now an IVF consultant working in Indira IVF Guwahati. So while talking to her, we were discussing what are the topics we should talk. Then we thought that this is a very important topic where endometrial receptivity is concerned. So for the infertility is concerned, it may be IVF, it may be IUI, where the endometrial receptivity is concerned. That is why we have included this. I think Dr. Jasmina will be talking something on what is endometrial receptivity and how it hampers, and detail will be discussed in the session by Dr. Irene. Thank you. Dr. Jasmina. Hello, Dr. Jasmina, are you there?
She is not there. So if Madam will just continue and introduce the topic, Nilakshi ma'am. Dr. Jasmina, I could not see on the list.
Okay. So it's embryo development and endometrial preparations are concurrent, but yet they're independent of each other. So there must be some synchronization. Is very critical to have an embryo implanted, there's addition, and then further continuation of the pregnancy. Different factors act on this. So I don't think I have to elaborate so much, and let us go to the talk straight away. Thank you. It's Irene. Dr. Irene, you can share your
Yes, ma'am.
slide.
A very good evening to Dr. M.C. Patel sir, Dr. Nilakshi Fukan ma'am, Dr. Aloka Goswami ma'am, Dr. Ina Datta ma'am, and other respected seniors and colleagues present in today's webinar. First of all, I want to thank you all, especially Dr. Nilakshi Fukan ma'am, for giving me the opportunity to speak on this topic. Today, my topic is endometrial receptivity. So what is endometrial receptivity? The period of endometrial maturation during which the trophectoderm of blastocyst can attach to the endometrial epithelial cells and subsequently invade the endometrial stroma and vasculature is known as endometrial receptivity.
Sorry for the interruption. Irene, you make it a full slide.
Okay, okay.
Okay.
Progesterone secretion is integral to this process as it brings the necessary secretory changes in the estrogen prime endometrium. The limited period of optimal endometrial receptivity in which the endometrium is ready to receive an embryo is referred to as the window of implantation and is generally detected between days 20 and 24 of a normal 28 days menstrual cycle. The window of implantation, it opens 4 to 5 days after progesterone secretion and closes within a short period, approximately at 4 to 5 days. The key findings in a receptive endometrium are histological changes and molecular changes. In histological changes, there is spinopods formation. These are the cytoplasmic projections of the luminal epithelium that facilitate the blastocyst adhesion. It appears 6 days after ovulation and are retained for approximately 24 hours. The molecular changes include expression of adhesion molecules, for example, integrins, cytokines, etc., immune protection, and appropriate gene expression. Expression of adhesion molecules, for example, integrins, are cell adhesion molecules that are involved in the cell-to-cell and cell-to extracellular matrix interaction. Cytokines are the glycoproteins produced by the trophoblastic and endometrial cells. It regulates the embryo-maternal interactions. The gene expression in a receptive endometrium, for example, Hox genes, these are upregulated by the estrogen and progesterone. These are essential for endometrial growth, differentiation, and receptivity. It is seen that women having a decreased expression of HOX-A10 and HOX-A11 during secretory phases has lower implantation rate. Also, expression of these genes is reduced in disorders like endometriosis, PCOS, hydrosalpinx, and fibroids. The ion channels in the endometrium, these also regulate endometrial receptivity and implantation. Abnormal expression or function may lead to impaired endometrial receptivity or implantation failure. The immune response in a receptive endometrium. For successful implantation, a balance between T helper 1 and T helper 2 produced cytokines is mandatory. T helper 1 cell produces pro-inflammatory cytokines, which increases the phagocytosis and inflammation. In contrast, T helper 2 cells produces anti-inflammatory response. In normal pregnancy, there is a shift towards the T helper 2 dominance. Also, disrupted population of peripheral or uterine NK cells leads to implantation failure. Now, the factors affecting endometrial receptivity. Number 1, uterine or anatomical factors. It may be congenital or acquired. Then endometrial thickness, altered expression of adhesive molecules, then immunological factors, endometrial microbiota, multifactorial factors. Coming to the uterine factors, these may be congenital uterine anomalies, for example, septate uterus, bicornuate uterus, etc. Studies shows that women who had undergone septal resection, they had better outcome following IVF treatment compared to the women who were untreated. The acquired uterine anomalies, for example, polyps, submucous fibroid, adhesions, hyperplasia, also have negative impact on the endometrial receptivity. Next, endometrial thickness. The optimal endometrial thickness threshold of 8 mm or more maximizes the live births. It has been suggested that ultrasound markers such as endometrial thickness, endometrial pattern, and indices of endometrial and subendometrial blood flows measured by a 3D power Doppler can be used to predict the outcome of IVF treatment. Altered expression of adhesive molecules, for example, local dysregulation of normal expression of cytokines can cause implantation failure. Elevated endometrial NK cells, dysregulation of the interleukin 12, 15, 18, and low interferon gamma and interleukin 10 were found in recurrent implantation failure. Now, the immunological factors affecting endometrial receptivity. The 3 main players of immune system affecting implantation are T helper 1 and T helper 2 balance, natural killer cells, and autoantibodies. As we already know, in T helper 1 and T helper 2 balance, in normal pregnancy, there is always a T helper 2 cells dominance. NK cells. There are two types of natural killer cells, peripheral NK cells and uterine NK cells. These two are different immune cells with different immunological property. Peripheral NK cells are first line of defense against tumor cells, viruses, and are cytotoxic in nature. Uterine NK cells are less cytotoxic in nature. Now, endometrial microbiota. It was assumed that uterus is sterile, and this was based on vaginal samples. Lactobacillus species is the predominant microbiome in the vagina, which may vary according to the age and hormonal milieu. Non-lactobacillus dominated microbiota correlated with adverse reproductive outcome, for example, failure of implantation, miscarriage, etc. Now, multifactorial effectors, it includes endometriosis, PCOS, and hydrosalpinx. It may cause implantation failures. Now, coming to the topic, how to improve the endometrial receptivity. It can be by treatment of uterine abnormalities if there is any, the treatment of thin endometrium, treatment of thrombophilia and immunological factors, treatment of multifactorial effectors. First, coming to the treatment of uterine abnormalities. If uterine septum is present, then we should do hysteroscopic septal resection. Polyps, hysteroscopic polypectomy, and submucosal fibroids or intramural fibroids protruding into the endometrial cavity by hysteroscopic myomectomy. Intramural fibroids abutting the endometrial cavity, we can do laparoscopic myomectomy. In adenomyosis, we can use depot GnRH agonist injection alone or in combination with cytoreductive surgery depending on the severity of the adenomyosis. In synecdoche, we can do hysteroscopic adhesiolysis with scissors. Next, treatment of thin endometrium, it includes endocrine strategies, aspirin or vitamin supplementations, and surgical strategies. In endocrine strategy, we have estradiol. It can be given by oral route or transdermal or vaginal route. Transdermal or vaginal route, it has higher serum estradiol concentration as it avoids the first pass metabolism. We can also give GnRH agonist injection in luteal phase, for example, triptorelin acetate 0.1 mg on the day of embryo transfer. It improves the implantation and pregnancy rate by supporting the corpus luteum. Next, we can give injection GCSF, which helps in implantation by regulating the expression of genes associated with embryo adhesion, cell migration, tissue remodeling, and angiogenesis, which are essential for endometrial growth. It induces trophoblast proliferation, invasion, and maintenance of pregnancy. Next, we can give PRP, that is autologous platelet-rich plasma. PRP is collected from the peripheral veins of the patient, and it consists of several growth factors like vascular endothelial growth factor, transforming growth factor, platelet-derived growth factor, epidermal growth factor, and other cytokines that stimulate the proliferation and growth. Next, treatment of thin endometrium with aspirin or vitamin supplementations. Aspirin, it improves the uterine endometrial blood flow. Then vitamin E and pentoxifylline has vasodilatory effect. Sildenafil citrate also augments the vasodilatory effect of nitric oxide. L-arginine also regulates the vasodilation and vascular flow as it is the main substrate of nitric oxide. Now, treatment of thin endometrium with surgical strategy, which includes diagnostic hysteroscopy. It can diagnose a previous unrecognized uterine pathology. Next, hysteroscopic cavity enhancement or endometrial scratching. The healing process following endometrial scratching, it may release cytokines and growth factor, which encourages the endometrial growth and facilitate the implantation. Then we can also give subendometrial PRP at the time of hysteroscopy. Next, treatment of coming to immunotherapy. It includes glucocorticoids, for example, prednisolone. It has an action of immunomodulation as it regulates the uterine natural killer cell count and stabilizes the cytokine expression profile. Then aspirin, it reduces the inflammation of the uterine cavity and it improves the uterine and ovarian blood perfusion. Then we can use heparin. It increases the trophoblast invasion. It controls the cell-to-cell interaction and helps in embryo invasion. Then we can give intravenous immunoglobulin as it reduces the peripheral cytotoxic cells. It enhances and regulates downregulation of the antibody-producing B cells. Then we can also give intralipid. Next, coming to the treatment of multifactorial effectors. If endometriosis is present, then we can give GnRH agonist depot injection. If hydrosalpinx is present, the accumulated tubal fluid may exert a direct embryotoxic effect, as it mechanically flushes an embryo from the uterus and may adversely alter the endometrial receptivity. In that case, we can do salpingectomy or laparoscopic proximal tubal occlusion, so that accumulated fluid cannot enter the uterine cavity. Now, the recent trends in ART in improving the endometrial receptivity. We are doing now ERA, endometrial receptivity array, and LIT. So ERA, we are doing in the patients with recurrent implantation failure, that is more than 2 implantation failures with good quality own embryos, or more than 1 failed implantation with good quality donor eggs. Or we can do ERA in patient with atrophic, that is less than 6 mm, or hypertrophic, that is more than 12 mm endometrium also. So ERA, it's a method to determine the personalized window of implantation for each patient by evaluating the endometrial receptivity. Since human implantation is a complex process requiring synchrony between the embryo and the receptive endometrium, which involves 248 specific gene expression. So this transcriptomic signature of window of implantation of endometrium can be identified by this microarray technology, that is ERA. The ERA, it involves the biopsy of the endometrium that is prepared for an embryo transfer. In hormone therapy cycles, endometrium is prepared using estradiol valeriate from day 2 of the cycle. Progesterone supplementation is started once the endometrial thickness is more than 7 mm, and biopsy is taken from the fundus of the uterus by Pipel technique after 5 full days of progesterone administration. In natural cycle, biopsy is taken after 7 days of LHRs or 7 days after HCG triggering. A separate kit is available for collection of ERA sample. Endometrial biopsy is taken using the pipette provided in the kit. Results are interpreted as receptive, pre-receptive, and post-receptive endometrium. Now coming to the lymphocyte immunotherapy, that is LIT. Now we are doing LIT in patients having unexplained recurrent spontaneous abortions and recurrent implantation failure. So the criteria of eligible patients are age 18 years or above, experienced 2 or more early abortions, had normal reproductive tract anatomy, normal chromosomal karyotype, and negative results for EPLA test. The immunological tests to be done before doing LIT are lymphocyte cross-match between wife and husband, that is donor, serum TNF alpha of wife, and serum NK cells of wife. In LIT, we take the donors, generally the patient's husband. We take 30 ml of fasting venous blood from the donor, and we isolate the lymphocytes by density gradient centrifugation. And we finally, 1 ml of lymphocyte solutions are intradermally injected to the patients through 5 points on the forearm. So now in our center, we are doing single sitting LIT. Thank you.
Dr. Amol, are you there?
Ma'am, can you please stop sharing your slides?
Yes, ma'am.
Amol Fukan, he was there, but
Nilakshi ma'am?
yeah, Dr. Amol Fukan was there. Actually, this is the clinic time, that's probably his thesis. I think it was a wonderful presentation. In a very short time, he has presented all the salient points regarding the endometrial receptivity, how to improve. So, Dr. Irene, I have few questions. Like
Yes,
you
ma'am.
said about to improve the endometrial thickness, practically what are the things you do in your practice? You have talked about PRP, you talked about medicine and all.
Yes,
Which
ma'am.
one? Yeah, carry on.
Ma'am, your voice is not coming, ma'am.
Hello, Irene.
Yes,
Can you
ma'am.
hear me?
Yeah,
So
yeah.
practically, what are the things you do, and what is your experience? Because a lot of things has been talked about to increase the endometrial thickness. You do GCSF, you do PRP, you do give medicines. Practically, what do you do, and what is your experience?
Sir, ma'am, practically we are using, ma'am, aspirin and aspirin tablet with every patient. And if the endometrium is less than 7 mm, we are doing PRP, ma'am, to every patient. 3-4 PRP we are giving.
PRP, you are getting good results?
Yes,
You are
ma'am,
getting
very good
You
results.
are good. Okay,
Yes,
thank you.
ma'am. Yes, ma'am.
So
And along with PRP, we can give injection GCSF also.
GCSF at one point of time it was used quite often, but are you still using? Because nowadays there are a lot of controversies are there with GCSF. It does not. It says it doesn't improve endometrial thickness so much as expected in the beginning.
Yes, ma'am. In some of our center, ma'am, we are using injection GCSF along with PRP together.
Yes. So, what is your opinion? The futuristic treatment, like, do you think that stem cell treatment may help in the future for improving the endometrial thickness?
Yes, ma'am. And in endometrial thickness improvement, ma'am, we should do hysteroscopic cavity enhancement also. That means endometrial scratching by hysteroscopy. It is also providing a very good result. After hysteroscopy, we can do PRP also.
Okay. So you were talking about your hysteroscopic myoma resection to increase the endometrial receptivity. So to the contrary, sometimes what happens if you use too much of energy, so endometrial
Yes, ma'am.
thickness, there is a lot of synechia, and if not synechia, there is a lot of damage to the endometrium. While doing the endometrial myoma resection, one must be very careful in judicious uses of the energy sources during myoma resection by hysteroscopy. Thank you. Anyway, it was a wonderful presentation, precise and very clear message. Thank you. Thank you, Dr. Irene.
Thank you, ma'am.
Thank you, Dr. Irene, for the wonderful presentation and great interaction by Nilakshi ma'am, who is the convener of this program and also chairperson of this session. So moving on to the next one, Jyoti, can you please take over?
Yes. And Kalpana, may I request from my side, I am unable to display the CVs actually. Asha madam is having the CVs. So for the next session, this is the star speaker, Dr. MC Patel sir, for the topic, what constitutes negligence in ART. For this, I am requesting as a chairperson, as Dr. Pranabika Mahanta madam. She is assistant professor come deputy superintendent in JMC Assam and resource faculty, NMC Regional Center of Faculty, and Secretary Jorhat and Obs-Gynae Society, organizing secretary in NeoGSCon. She is specialized in the Obs and Gynae, and her city means she is residing in the Jorhat, and senior as she is having the vast experience of 17 years, and she is having the advanced diploma in the ART and reproductive medicine, and she has done the basic course in biomedical research in the ultrasonography, endoscopy, and IOI. We welcome you, madam. Our next chairperson is Dr. Hemkanta Sarma sir. He is a professor and head of the department in the Jorhat, head of the Department of Obstetrics and Gynecology in the Jorhat Medical College and Hospital, Jorhat, Assam, India. He is editor-in-chief in the New Indian Journal of Obs-Gynae, founder, president of the Obs-Gynae Society of Barpeta, Assam, India. He has innovated the techniques of VVF repair and innovated techniques of radical hysterectomy. We welcome you, Hemkanta Sarma sir. Our third chairperson is Dr. Pankaj Kumar Barua sir. He is the senior consultant at Sanjeevani Hospital, Jorhat, Assam, the vice president of Jorhat Obs-Gynae Society and past secretary of Jorhat Obs-Gynae Society. He has been presented and published various papers at many national and international conferences. We welcome you, sir. I request Dr. Pranabika madam to introduce our speaker, Dr. MC Patel sir. I request Dr. Hemkanta Sarma sir to just open the topic by giving few insight of the topic, and request Dr. Pankaj Barua sir to conclude the topic. So I am handing over mic to Pranabika madam. Madam, are you there? Pranabika madam. Pranabika madam. Sir, I request Dr. Hemkanta Sarma sir to introduce and open the topic.
Okay. So good evening. Good evening, everyone. Am I audible to you?
Yes, you are audible.
Yeah. Good evening, Dr. Patel. Good evening, everyone. Namaskar. So I am introducing Dr. Patel, and he is known to everybody, and he is a consultant obstetrician and gynecologist and medical legal counselor. He is the Vice President, FOXI 2018, Organizing Secretary, AICOG 2017, Chairperson, Ethics and Medical Legal Committee, FOXI 2011 to 13, and Honorary Secretary, State Organization and Gynecologist and Obstetricians of Gujarat 2022 to 24, and Organizing Chairperson of MMCon 2018, then Honorary Member, National Inspection and Monitoring Committee, DCPNDT, Government of India 2015. Then he is the Honorary Member, State Supervising Board, PNDT Committee, Gujarat State 2005 to 9. Then he is President of Ahmedabad Obstetric Gynae Society 2010 to 11, and Honorary Member, National Managing Body, Indian Red Cross Society, Headquarter 2019 to 22. Then he is also National President of National Medicos Organization 2016 to 18, President IMA Ahmedabad Branch 2007 to 8, Honorary Surgeon, Indian Red Cross Eye Bank, and collected more than 1,000 eye pairs. And as a chairperson, Vivekanand NMO Conference 2013. So he is known to everybody. Everybody knows him, and he is a honorable faculty, and he has got vast experience on this subject, and especially the medical legal aspect. So I welcome Dr. MC Patel, and I also say that in the modern era, few words regarding the topics. Actually, in the modern era, we find that there is incidence of infertility is coming up, and as well as the ART is also coming up in a large way. There are different methods, newer methods are coming up, and we also found that there are a lot of cases in Consumer Protection Act, and people are also aware about all these things. And ultimately, we find that all this leads to a lot of medical legal problems. And very often the questions of medical negligence comes when you go for ART. So I think it is a pertinent, and it is a really useful topic to discuss. And we will learn something from our honorable guest, honorable speaker, and with his vast experience on this subject. So let's listen to him.
Thank you, M. Kanta sir, for kind introduction and opening the topic. Let me share my screen. Is it seen full screen?
Yeah.
Yes. So, greetings from Statue of Unity, tallest statue of world, and we all are proud of that statue. ART, what constitutes negligence in practice of ART? Because since so many years, there are almost mushrooming of ART clinics, and recently ART Act has also been enacted in Lok Sabha and Rajya Sabha, and now it has become ART Act, and it governs ART practice. So warm welcome all the delegates, and wishing you a litigation-free practice. At the outset, I would like to thank all the societies of Assam who have joined this webinar, and all the president and secretary of respective society, and all the delegates who have joined this webinar. Usually I start any of my talk with this question: is it worth discussing? Yes. And if it is yes, then why? Because medical legal litigations are increasing in number constantly and steadily, and we gynecologists rank first as far as medical legal problems are concerned. So let us see what is negligence as such. So in our undergraduate curriculum in forensic medicine, two words were taught: act of omission and act of commission. So act of omission means not to do something which a reasonable prudent doctor would do, and act of commission means doing something which a reasonable prudent doctor would not do. Say for example, in any case, if injection penicillin is to be given, then naturally prudent doctor will go for negative test dose and then he will do. If test dose is not done, then it becomes a act of omission. An act of commission, say for example, if it is a planned surgery and patient has come with full stomach, and if surgery is done under general anesthesia, then it becomes an act of commission. Because in this given situation, prudent doctor would not do this type of surgery with full stomach when it is a planned surgery and it is under general anesthesia. So, as far as negligence is concerned, it is breach of legal duty or care owed to the patient by doctor, whereby patient suffers damage. It could be physical, it could be psychological, or it could be financial. So there are 4 ingredients of negligence. First is existence of legal duty. Whenever any patient enters in your clinic and you accept her to treat, then it becomes a contract between patient and yourself. You are offering your expert services and patient pays for that, or patient promises to pay for that. So as soon as you accept any patient to treat, your legal duty starts from that point of time. So existence of legal duty should be one more criteria as far as negligence is concerned. So just I mentioned, it is a contract or implied contract of personal services. So legal duty stems from acceptance of the duty in a legal way. Breach of that duty. So once we have accepted to treat, then we are under obligation to take utmost care of patient as per standard medical norms. And if there is breach of that duty, there is carelessness on part of treating doctor or negligence, so it is a breach of that duty and damage suffered by patient. So due to that breach of duty, if patient has suffered damage, it is one more ingredient of negligence. And very important ingredients of negligence, doctor's conduct is the direct and proximate cause of such damage. So action of doctor should be direct and proximate action to cause damage to the patient. So if these 4 criteria are fulfilled, then only in court of law, negligence against doctor is proved. It could be civil negligence or it could be criminal one. But there are certain situations in our day-to-day practice, and they are common allegations, how we may end up into litigation and we have to go for compensation, face litigation and pay compensation because delayed in diagnosis, investigation or treatment, sorry, misdiagnosis, investigation or treatment, wrong diagnosis, unnecessary investigations, no proper consent, staff not qualified, infrastructure issues, emergency services not rendered properly, communication failure, patient or patient party are not communicated well, delayed in transfer, if at all we have to refer patient to higher center for some reason, then if it is delayed in transfer, this also be one more area for litigation. Complications, as far as any ART treatment related complications like OHSS in hyperstimulation and multiple gestation, in case of fetal reduction, possibility of infection, hemorrhage, injury to surrounding structure during any procedure related to ART. So any of these complications may invite litigation and it becomes a potential area for litigation. Morbidity, it is of course very rare, but if at all it happens, then maternal and or fetal morbidity may invite litigation. And same way, mortality, maternal and or fetal, it is also one more area as far as litigation is concerned. Overcharging, because as far as ART treatment is concerned, we know it is very expensive treatment. So tremendous expense against unexpected result could be one more area as far as litigation is concerned. And ask for medical record and not provided, because we are under obligation to provide record to the patient or eligible relative of patient within 72 hours as per MCI guideline and within 5 working days as per newer NMC norms. So we should provide all the records of treatment given to the patient. Failure of patient to comply with scheduled follow-up. Many times patient doesn't comply with our instruction. And if something goes wrong, then it becomes a contributory negligence on part of patient, and it becomes a good defense in your favor. But as far as ART treatment or complication related to ART procedures are concerned, many a time this is area of litigation not anticipated or not prepared to manage. So many times this question is asked. Say for example, if OHSS happened, then in court of law this question can be asked. Was it preventable? And usually you cannot say no. And if it is yes, then what did you do to prevent it? And if you couldn't prevent it in spite of all your care and caution, if you couldn't prevent it, then this question may also be asked, why you couldn't prevent it? And one more area, did you diagnose in time? If at all complications happened related to any procedure of ART, did you diagnose in time? And very important question, did you manage way in which any prudent doctor would have managed? So in that given situation, any prudent doctor, how he would have managed, you should have managed the case, is expectation from court and law from us. Let us see few of the important cases which were decided in different courts. In this very case, it was misleading advertisement in camp, no result, no money. Investigations and treatment, patient was investigated, and in camp there was advertisement, no result, no money. Patient had been to clinic, patient was investigated, and patient was treated. Rupees 90,000 were collected. Later on, endometrium was not good, so embryo transfer was not done and cycle was cancelled. And case was filed by patient because hospital didn't return all the amount collected as hospital had promised, no result, no money. So at the time of deciding this case, judgment given by honorable court, but inference held by the court was, those center must have incurred cost in stimulation and pickup, but since it was promised that no result, no money, then amount is to be refunded fully. So in this case, judgment was in favor of patient and total amount was to be returned to patient. Many a time, this type of advertisement are given by some clinic and few of our friends. If first cycle fails, second cycle will be free. Is it ethical as per NMC norms? Can they suspend license of doctor in this type of situation? Any legal issue? Can one give guarantee? So no one can give guarantee about result, because we know as far as ART treatment is concerned, 100% guarantee cannot be given. And in one of the cases, it happened in city of Mumbai only, guarantee was given and result was not there, and case was filed and case was decided against doctor, and it was communicated to National Commission also, Medical Commission, and for 6 months license of that doctor was cancelled by NMC. So in this type of situation, as far as result is concerned, you cannot give guarantee. Of course, money back guarantee could be given, because in this you are not giving guarantee of result. If there is no result, money will be given back. So it doesn't become any legal issue or ethical issue. But as far as the result part is concerned, you cannot give guarantee. And if at all you have given guarantee, and if you cannot give result, then it becomes a troublesome and it becomes an area for litigation. One more area. अरे यार पैसे तो गोनेडोट्रोपिन में है. Many of our consultant, IVF consultant, usually dispense gonadotropin or any other drugs related to ART from their own clinic, and many a time it is very in a lighter way. It is called IVF consultant sell gonadotropin for a profit margin. So is it allowed under pretext that I am using for my patient? So it is very clear, and it is sell versus use or sell versus provided medicine for their own patient only. And as per the controller office, it is very specifically mentioned that doctor can legally dispense. So doctor can dispense medicine to his or her patient only, or he can give those medicine to other doctors also. But he cannot sell to any other patient on prescription of other doctors. So if patient comes with prescription of other doctor, doctor cannot sell that medicine. It is very clear. So he can dispense for his own patient, or he can give medicine to other professional colleague. Cannot open shop or cannot import drugs. And if at all he has to import any drugs, then special license from drug controller should be taken. Have to keep all the records. Even if he is dispensing the medicine, but he will have to keep all the records. And now there is guideline in ART law also, ART Act also, and specifically batch number and expiry date is to be mentioned. Total amount purchased, in which patient how much amount of medicine was used and how much is the stock. So that way, that is prescribed register, we will see little later on. Let us see one more issue, and in this particular case, Rajendra versus Mrs. Cadential Hospital, it was decided in state of Kerala. ICSI with sperm derived from testicular biopsy for a couple with male factor. Husband had a azoospermia and wife had a PCOS. So in this particular case, ICSI was decided and 2 cycles were failed and it was successful in 3rd cycle. Proginova and natural progesterone were prescribed for support, and there was allegation on part of patient that she was advised by a doctor to have complete bed rest, but it was denied by doctor in a court of law at the time of prosecution. So she had ended into pulmonary embolism and case was filed, and this was the allegation. I was advised complete bed rest, and due to complete bed rest, there was thrombosis and thromboembolic phenomena, and I suffered pulmonary embolism. So there are some special situations in our ART practice. ART done and donor gametes used. Is it adultery? No. If consent of all the partners involved in the ART are taken, then there is no adultery. Artificial insemination with donor without husband's consent, can it be ground for divorce or judicial separation? Yes, because it is very clear as far as ART Act is concerned. All the party involved in ART procedure should have knowledge about this procedure, and consent of all the party involved should be taken. So in case of artificial insemination with donor, if consent of husband is not taken, it becomes a very difficult situation if at all litigations happen. In case of artificial insemination with husband, in this, husband never had an intercourse willfully or because of impotency, and with special treatment, patient was pregnant. Is it considered as a consummation of marriage? Can decree of nullity be granted in favor of wife for divorce under impotency? So in this case of artificial insemination with husband, it was testicular aspiration of sperm and ICSI was done and patient was pregnant. And on this ground, patient has asked for divorce. So it is not consummated, and decree of nullity was possible in this particular case. And under Indian Evidence Act, child born within 280 days of dissolution of marriage, then this child is considered as a legitimate child in case of death or divorce, if at all it happens. And if it is allegation, then under Indian Evidence Act, it is the situation. But if it is done with store sperm of husband, then this doesn't apply in this type of situation. What happens if the DNA of baby doesn't match with genetic parents? Many a time this becomes a very troublesome to clinic or lab, particularly when it is a mix-up and when commissioning couple is not genetic parents of baby deliver, and it becomes a very troublesome. The DNA of surrogate baby doesn't match with genetic parents. This is also one more area. Is it intended parents still bound to accept the baby? So as far as surrogacy contract is concerned, it is as per standard prescription in ART Act. So how at the time of this surrogate contract, how the commissioning couple and surrogate couple had a contract and all the provisions accordingly that it should be decided. But in this type of situation, if commissioning couple has given consent, that is in any condition, they are under obligation and they will accept the baby, then they will have to accept baby. Of course, they can sue the ART clinic and ART lab for mismatching, but they will have to accept baby in this type of situation if they have given consent in this regard. If consent is very clear that in this type of situation, when DNA is not matching, then he can deny custody of baby. In this type of situation, in surrogacy contract, it is mentioned when couple is not ready to accept baby, or if there is a death of both the partner of commissioning couple. In this type of situation, if family members of commissioning couple are ready to adopt child, and if they are eligible to have adoption, then with due legal procedure, adoption can be done, or baby can be given to some organization and they take custody of baby and they invite any interesting couple for adoption. So it is very clear in surrogacy contract. So at the time of doing this contract, surrogacy couple and genetic couple should have a very clear in their mind as far as contract is concerned. Death of egg donor. In this type of situation, many a times it happens that during procedure or just after procedure, if at all death of egg donor, what is medical legal scenario? What is the role of ART bank in such a situation? So here comes a role of ART bank and ART clinic both. As far as ART bank is concerned, was egg donor properly screened? Was she eligible or she was fit to go for egg donation? So all these points are taken into consideration in this type of situation. And we should be readily available to prove all this by our record that we had screened very properly as far as screening of egg donor is concerned. And we have to face all this litigation. What is the role of ART bank in such situation? Just I mentioned. Is it legally correct if wife without husband's knowledge request for egg donation? No, because in ART Act it is very clear. Whenever patient is willing to go for egg donation, and if she is eligible, if she is married, then consent of husband is very much must. If she is not married or if she is single, then it is a different story. But if she is married, then consent of husband is very much required. Is it legally correct to use donor sperm with only husband's consent without wife's knowledge or vice versa? Same. In this situation also, consent of wife is also very much needed, because all the party involved in this program should have a knowledge and they all should give their consent. This is very interesting situation. Embryo develop and before transfer, death of husband. can wife use this embryo? So again, it will be a role of consent. If at the time of giving consent, if husband has given consent like this, that in event of my death, this embryo can be used by my wife as per her wish, then she can use those embryo in future program. Same way, if at all it is a death of wife, then one more question, can husband use in her friend or second wife? Again, comes a role of consent. So in consent, if wife has given consent like this, then in this situation, that embryo can be used by husband. One more interesting situation, if death of both commissioning couple, husband and wife, and embryos are developed, can father of husband claim embryo? One more area, can father of wife claim embryo? So in this type of situation, again, role of consent comes, and in consent, if specifically given consent like this, then father of husband or father of wife can have a custody of embryo, and they can utilize those embryo. But usually at the time of consent, it should be very clear one. So what to do not to end up into litigation related to ART practice, and how to prevent? It is very obvious under ART Act, no ART clinic bank can function without registration. So registration of center is very much mandatory. Your center should be registered. No center can function without surrogacy as far as surrogacy services are concerned. So either your center should be registered as a ART bank, ART clinic, and or a surrogacy clinic as per your practice. It is very much mandatory. Foreseeability or anticipation. Court or law expect from us to anticipate certain complications related to ART procedure or ART treatment, and we should be readily available to deal with situation in any given situation. Say for example, if it is a hyperstimulation, then we should anticipate in advance that certain cases may go into hyperstimulation. So we should select a protocol as far as induction is concerned accordingly, not to end up into OHSS. And if at all it happens, then we should be readily available with all intensive care to deal with situation accordingly. But in all this situation, proper counseling with patient and patient party before starting any program of ART is very much required. And no rosy picture about result, no tall claim about result, because we know ART practice limitations. So we cannot give guarantee or give rosy picture, because in our practice, if we consider our result like Aishwarya Rai, but it may turn like this anytime. So no rosy picture, no tall claim, because in eye of law, when you claim to be master, you are supposed to be master. So proper communication with couple in ART practice is very much needed, and documentation. Whatever you counsel with the patient, you should document everything in a very effective and efficient manner. Because in this famous case of C. Jaipal Reddy versus Padmini Velluri, National Commission has very specifically mentioned that consent is not mere piece of paper on which patient and his relatives should sign, but consent should be considered as a document of proof of communication. So whatever you have communicated to the patient and patient party, or whatever you have counseled, each and every point should be entered in consent paper, and then patient and patient party should sign. And once they sign, it becomes a documentation of your communication. And when you offer all those documents in court of law, it becomes communication of your documentation. But records are always at your rescue. So keep them up to date. What was done, nothing was neglected, given treatment fully met with standard demanded by law and ethics, and it should be easily acceptable whenever offered in the court. And ART Act has prescribed all the forms, in which condition, which form is to be filled up, it is very clear. Say, for example, form 1, it is for application form for registration of ART clinic. Same way, form 2, application for registration of ART bank. Form 3 is a certificate of registration. If center is allowed registration, then in form 3, registration to ART clinic level 1 or level 2, as per the case may be, and ART bank, this in form 3, registration will be given. It is again prescribed form. If there is a problem on part of patient, I mean a part of this clinic, if registration is denied for any reason, then they can go for appeal in prescribed form, that is form 4. Form 5 is format of making complaint to grievances cell, because under ART Act, now it is compulsory for every ART bank, clinic and surrogacy clinic to form grievance cell. And if at all any patient or patient party has a grievance, dissatisfaction, then they can approach that grievance cell, and there is a prescribed format how to apply in grievance cell for their grievance, and it is given in form 5. As far as form 6 is concerned, it is to be signed by couple or woman as per the case may be. Form 7, IUI with husband semen or sperm. Form 8, IUI with donor semen. Form 9, freezing of embryo. Form 10, freezing of gametes, sperm or oocytes. Form 11, for minor, if patient is minor, and if freezing of gametes, either sperm or oocytes, are needed. Say, for example, if she is suffering from some ovarian carcinoma, and all these gametes are to be preserved for future consequences, then with consent of parents, this procedure can also be taken, but there is prescribed form, that is form 11, and this form 11 should be filled in this type of situation. Form 12, it is for oocyte retrieval. Form 13 for oocyte donor. Form 14 is record of use of donor gametes. So whichever donor gametes you have collected and you have preserved, you should have a record. It is prescribed form. Form 14 with all these column, name of donor, age, its address, then all these details, when this was collected, when it was preserved, and whenever it is supplied to ART clinic, this is also to be mentioned that to which clinic it is supplied. So it is very prescribed form as far as record of use of donor gametes are concerned. Form 14A, it is for oocyte donors. Again, it is also very prescribed form, and all the details we have to fill in that form. 14B, it is for oocyte or embryo record, and all the columns we have to fill very carefully. Form 15, that is consent form for donor of sperm. But in all this situation, all the party involved in ART clinic should have a informed consent. Are your patient properly informed? It is the requisite on part of law as per ART Act. And doctor is bound to produce record whenever asked by the court. And if he doesn't, then adverse inference might be drawn. And it is very obvious. Good record is good defense, poor record is poor defense, and no record is no defense. And it has been my experience during my medical legal practice. We doctors are very poor as far as record keeping is concerned. So to conclude with carry home message, not to end up into any kind of litigation, standard protocols we have to follow. There are standard protocols given as per ART Act guidelines also. So we have to go with standard protocols, adequate supervision and monitoring during, not from the screening to end of the result. So we have to go with adequate supervision and proper monitoring as far as treatment part is concerned. Proper communication, counseling and consent, proper documentation and record keeping, foreseeability or anticipation of certain complications, and we should be readily available to deal with situation. Multi-speciality approach. If at all any professional colleague is to be involved, then they should be involved since point one, because it shows your consent to take utmost care of your patient. So multi-speciality approach is also very much required. Prompt diagnosis with necessary investigation in case of any complications related to ART procedure. Qualified anesthesiologist. Whenever you are dealing with any procedure, you should have qualified anesthesiologist. Audit of your own medical case, where thing went wrong. And if we go with our own audit in our case, then we may improve our practice in future. This gentleman has so many staircases, but he doesn't know how to use them. So it doesn't matter how many resources you have. If you do not know how to use them, they will never be enough. There are so many provisions in ART Act also in our favor. But if we do not know, then they won't be useful in our favor. So have some basic legal knowledge. Always obtain medical legal advice whenever you are in doubt. And if you want to sleep like this, take tender care of your patient. Comply with the provisions of ART Act. Pray your Almighty God before going to sleep, and keep my visiting card below your pillow. And this is law of leopard behind innocent gynecologist, and see the role of medical legal counselor, how he can be useful in any given situation. So please do not hesitate and have a phone call to medical legal expert in any given situation. So God bless you. Have a litigation-free medical practice. With regards, salute to all the societies who have joined this webinar. Thank you very much. Please do not assume. Please ask if at all any query, any question, if time and chairpersons permit. Thank you very much.
Thank you very much for an excellent talk. To any question, queries from the audience, please.
If there is no question, then we can proceed to further for next session. Yes, Kalpana.
Yes, sir. Actually, your talk was very informative, and it is really needed when there is so much of confusion as far as this ART bill is concerned, level 1 clinic and level 2 clinic and bank. Your talk gives us a clear message for the delegates. Thank you so much, sir, for the extensive talk. Now moving on to the interesting panel discussion. So it is my pleasure to invite the moderators of this panel discussion. Can we have, Dr. Pratibha Pasare Agarwal, ma'am, who is an IVF specialist at Apollo Fertility, Guwahati, Secretary of ISOPARB Assam chapter, EC member of Guwahati OG Society, presented many papers in various conferences. Madam's interest is dealing with repeated IVF failure. So welcome, ma'am.
Thank you so much, ma'am. Thank you.
Our next moderator is Dr. Isha Goyal, ma'am, who is also practicing in Guwahati Medical College and also Assam. She has been trained in infertility from Hinduja Hospital, Mumbai, and also laparoscopy from Eva Hospital, Ahmedabad. Currently working as Registrar, Department of Obs-Gyn, Guwahati Medical College. Welcome, ma'am. We have experts, Dr. Sneha Bhuya, ma'am, who was a dynamic past breast committee chairperson, 19 to 21. Madam was also governing council member of ICOG 21 to 22. Suffolk Working Committee member, breastfeeding, and she is the dynamic amongst Medical Disorder Committee chairperson right now, 22 to 24, founder president of Vidarbha ISOPA. She's received prestigious awards, IMS Signature Award, GCC Award, SN Malhotra Individual National Award, Durusha Community Service Award, Anandibai Joshi Award, and she has got almost 20 years of experience in OBS-GYN. Welcome, ma'am. Our next expert is Dr. Rekha Rajendra Kumar, who is a medical director, Miracle IVF Center and Chandana Hospital, President-elect BSOG, South Zone Coordinator of FOGSI Infertility Committee, Chairperson of Infertility and Viati Committee, Kasoga, received various awards, and she has got very good teaching experience and published many papers and faculty in various conferences. Welcome, Dr. Rekha. Our next expert is Dr. Bharti Rajshekar, who is a medical director, OBS-GYN consultant, Vatsala Hospital, Hassan, Honorary Secretary, Kasoga 20 to 22, KPMA State Vice President, and also Indian Red Cross Director, IMA Karnataka State Past Vice President, Hassan Uji Society Past President, PCPNDT Committee Member, FOGSI Food and Medical Equipment and Drug Committee Member, recipient of various prestigious awards, faculty in various conferences. Welcome, Dr. Bharati. Our panelists here are Dr. Jury, who is a chief consultant in Matrika's IVF clinic, Dr. Shubhendu Mala, visiting consultant at Downtown Hospital IVF Center, Guwahati, Dr. Shweta Banchali, Madam Consultant from Marwari Hospital, Guwahati, Dr. Deepak Sharma, sir, Consultant in Marwari Hospital, Guwahati and Apollo Hospital, Guwahati, Dr. Kanchan, Senior Consultant, IHR, Guwahati, Dr. Mukesh Fogla, Director Chief Consultant, Global Fertility Center, Dibrugarh, Dr. Devanjana Datta, Secretary of Silchar OG Society, Sumita Gogi, Consultant Gynecologist, SSB Composite Hospital. Welcome, panelists. We are looking forward for an interesting panel discussion. Over to you, moderators.
Yeah, thank you so much, ma'am. Thank you. I would like to share my screen now. Yeah, visible?
Yes, make it full screen.
Yeah.
Make it full screen if possible.
I'm doing it. Yeah, yeah, is it full screen now?
Yes, ma'am.
Yeah, so PCOS is a complex endocrine disorder affecting women of reproductive age. It is characterized by increase in androgen production and ovulatory dysfunction. It is one of the leading causes of ovulatory infertility. Women with PCOS have increased risk of insulin resistance, hyperlipidemia, type 2 diabetes, cardiovascular disease, and endometrial cancer. So WHO classification of anovulation says that PCOS is type 2 class of anovulation, and it accounts for more than 90% of the cases. To diagnose PCOS, we have the Rotterdam criteria, which says that PCOS is defined by the presence of any two of three of the following criteria: with anovulation, hyperandrogenism, and polycystic ovaries. So because anovulation is the most important criteria, we have today the panel on ovulation induction in PCOS. So we moderators, I am Dr. Pratibha, and with me I have Dr. Isha. We welcome all the panelists, and I request all the panelists to please have their videos on so that we can see them. हम लोग का कहाँ पे है? Yes. We don't have Dr. Subhendu with us because of some medical emergency at home. So we welcome all the panelists, Dr. Mukesh Fogla, Dr. Kanchan Murarka, Dr. Smita Gogai, Dr. Judy Khanikar, Dr. Deepak Sharma, Dr. Shweta Bhanshali, and Dr. Devanjan. So moving forward, we have the first case. 25-year-old lady married for 1.5 years, complaining of irregular menstrual cycles and unable to conceive. Her weight is 83 kgs with BMI 31.2. The husband's part is normal semen parameter. How would you like to proceed? I would like Dr. Shweta Bhansali, madam, to please answer this question.
A very good evening. Like in this case, she is a young obese lady with delayed menstrual cycles. So I would like to actually take a more detailed history regarding her menstrual pattern, that her menstrual cycle is delayed by how much. That means whether she is like having a mild oligomenorrhea or a severe oligomenorrhea, whether she's having any history of galactorrhea, that is very important. Then any family history of PCOS or diabetes. Then what is her lifestyle way? Okay, that means whether she's a sedentary or she is an active lady. Again, like in the examination part, I would like to see the signs of hyperandrogenism in the form of acne, hirsutism, or alopecia. Then acanthosis nigricans, I would like to look for skin tags, which will give us a hint of insulin resistance here. Next, for the examination, for the investigation part, I would like to go for the screening for thyroid, TSH, prolactin. Now, as she's a young lady, I would also like to go for a 17 alpha-hydroxyprogesterone and day 3 ultrasound, TVS pelvic organs to see the PCO morphology here, and a day 3 basic basal level of FSH, LH, and also I would like to do AMH in the same setting.
So the investigation, as you say, Dr. Shweta, that you would like to go for day 3 ultrasound, you said, right?
Yeah.
To see the PCO morphology. So is it only day 3 that you see the PCOS morphology? Or you can, patient has come to you at say day 18 of her menses, and would you ask her again to come on day 3 just to diagnose PCOS?
No, like say, like when we do an ultrasound, we will see basically our aim actually here is to see the antral follicular count as well as the endometrium here. So basal, in the initial part of the cycle, if we do a TVS, that is much better. But yes, if she comes anytime, we can always go for the ultrasound here.
So the evidence says it is not that we do a day 3 ultrasound to diagnose PCOS. It is any time of the cycle the patient comes, the PCOS morphology is there, and we diagnose PCOS accordingly. And you said AMH. So is it necessary to do AMH in all patients of PCOS?
No. It's not like that. AMH is not the diagnostic criteria for PCOS as of now. But AMH, in any case of infertility, like we would like to go for an AMH value here.
Yeah. So our take is that AFC is more important.
Yes.
So the diagnosis is said that by any of the 3 criteria, we take 2 out of the 3 criteria. So for anovulation, what do we look for? We look, this is a chart showing anovulation if she has oligomenorrhea, cycles more than 35 days apart or less than 8 menses a year. And to rule out hyperandrogenism, biochemical we have to do testosterone, as you mentioned. So if the testosterone is not elevated, we can go for DIA or epiandrostenedione. And regarding PCO morphology in the scan, we need to see that both ovary contains 12 or more follicles measuring 2 to 9 mm in diameter, or the ovarian volume is more than 10 cc. So these are the actual criteria which we look for in the TVS for to diagnose PCOS. Now, is there any way to know the severity of PCOS? I would like Dr. Devanjana Datta, madam, to please explain this. Madam Dr. Devanjana Datta, are you there? So in case she joins again or she hears us, may we request Dr. Sumita Gogoi, Madam, to please.
Yeah, ma'am, I'm there, but
Achha.
I'm not getting the, your voice isn't coming up. I mean, would you be a little bit lucid? I'm not getting the.
How do you know the severity of PCOS? You have diagnosed this as a case of PCOS. Now, how do you know the severity of PCOS? How severe it is? Did you get me? Maybe there is some network problem with her. Dr. Sumita Gogoi, Madam, can you please explain this if you are here? Dr. Sumita Gogoi, is she there?
1 minute. Okay, the question here is, how do we know the severity of PCOS? A would be the history, for how long she has been having irregular cycles, 6 months, 1 year, 2 years. B, examination. We take the basal we take the BMI, and also I think an important marker would be the waist hip ratio. If it's anything more than 0.85, that would be indicate that she has been a case of long-standing PCOS. Thus, we also look for the central obesity, which is diagnostic of PCOS, with the clinical markers like your acne and hirsutism, acanthosis nigricans. So that would be like a good clinical way of judging the severity of PCOS, depending on the features. As we said, the transvaginal ultrasound is a good way of looking at the ovaries. So you have like a very large volume size of ovaries both ways and both sides. That would indicate that the case has been a PCOS for a very long time. And I think if I think of treating this patient, I would like to have a look at the AMH as well. And that would like give us an indication as how long standing this would be. So it's, I think, a complete picture, taking into account the history, the clinical part, as well as the ultrasound scans.
Definitely, I will suggest the severity of PCOS, but there are certain phenotypes of PCOS.
Yes, yes.
Phenotypes of PCOS, A,
Yes.
B, C, and D.
Yes.
Now, in type A, where we have all the three criteria, Rotterdam criteria to diagnose PCOS, that is hyperandrogenism with hirsutism, ovulatory dysfunction, and PCO morphology. And
Yes,
this is the most severe type. And type D, where we don't have hyperandrogenism. So hyperandrogenism is the most important factor to determine the severity of PCOS. Whether we go for looking at the ovaries or the AMH or any values. So if there are features suggestive of hyperandrogenism, basically hirsutism and the acanthosis nigricans, which is very much suggestive of insulin resistance due to hyperandrogenism. So this is the most severe form. And if we do not have hyperandrogenism and the other two criteria, then those are the least severe ones. So these phenotypes indicate the severity of the PCOS, right? So we move forward to the next case.
So we have another case. So this is a young patient, 29 years old. She's just married for 2 years. She has come to us. She's obese. Her BMI is 37.5 and she's presenting with primary infertility. Currently, she has giving history of amenorrhea for 2 months. She's a full-blown PCOS. She has acne, hirsutism, and already diagnosed case of PCODs. We have already seen the semen parameters, which have come out to be normal. So my next question is for Dr. Kanchan, ma'am. So how will you manage this patient, ma'am? How will you like to proceed? Please unmute yourself.
Yeah, thank you so much for the question. So here I would like to say is that first I would like to investigate the patient thoroughly because here we cannot see her hormonal profile. So I would like to do the thyroid, the prolactin and everything, and the HSG also. And Though, yeah, the clinical features are very much relevant of, actually, we have already done the TVS, which shows the bilateral facial morphology, right? So after the full evaluation of the patient, since the patient is very young, only 29 years old, and the BMI is also very high, 37. So first, my first line of treatment, advice, I would like to advise the patient the lifestyle modification and weight loss. So first, I would like to tell her just to go ahead with the weight loss, the diet and exercises and all. So here I would at least want her to, the BMI 37 is actually very high. So I would like at least she decreases her weight. She is somewhere, around at least 10 to 15% of her weight, which is 86. So after that, after the weight loss only, we can, if all parameters are normal, if the tubal, the HSG is normal, if everything is normal, then after weight loss, first I'll give her time for weight loss, and then I can go, we can still, if she's not, like after weight loss, many patients start ovulating by themselves. If still she's in the anovulation, then I would like to go ahead with ovulation induction and time cutters for my first goal.
Dr. Kanchan, the patient has presented with infertility, amenorrhea for 2 months with the features of PCOS. So you are straightforwarding, like giving her advice for weight loss and everything. Would you like, she would definitely like herself to be managed for infertility and amenorrhea. So the first line in this case, to rule out pregnancy. She's 29 years old, married for 2 years.
Yeah,
and
that's what I do. First, we will do all her investigations because the thyroid and everything, that's all is not done. So we will do that. Yeah, we will rule out pregnancy also.
After she is negative for pregnancy, we are going to give a withdrawal bleeding. And then we would advise her for all the special tests, which has not been present here. And also we would give her advice. Now, as you said, we would give her advice for weight loss. So the first line of management says lifestyle modifications, which includes diet and exercise. So next question to Dr. Mukesh Fogla is, what advice would you give her for her weight loss and for her diet? Dr. Mukesh, are you there?
Yeah. For diet, I think we should give her a low carbohydrate, low fat diet and high protein and aerobic exercise, walking, gym, Zumba.
Any evidence-based?
Evidence-based.
So the evidence activity.
I cannot give you an expert opinion on this.
So
but I think a low fat, low carbohydrate diet and aerobic exercise.
So
that should be the basic
based criteria for this, which says that physical activity, 20 minutes of moderate intensity physical activity, 5 days a week. It is to be done for diet, and losing 5 to 10% of the body weight will help to reduce the insulin levels, the androgen production, improve the testosterone levels, induces ovulation, and reduces the miscarriage rate. And regarding diet, it is said that we should offer them a 30% calorie deficit diet, and to allow them around 1200 to 1500 kilocalories per day with a high fiber, high protein and a low carb diet, as you said. So this is evidence-based guidelines. How much time will you give for the desired weight loss? May I ask Dr. Julie Khanika madam to please explain this?
Yes, thank you, Pratibha. How much time, question is how much time will you give for the desired weight loss? As we know that PCO patients, it's very difficult to lose weight easily. Even if we give the advices for the diet, it is very difficult. So along with the diet exercise, I would like to start metformin. It's a very good drug for PCOS. So the time for usually I call the patients after 2 months. For 2 months for weight loss, if she lost weight for at least for 5 to 10%, then also we get good results. And along with that, I give the medications also, metformin, and any surgery. I don't think she require any surgical intervention because motivation, good counseling, motivation, it's very important for the practice. So we have to counsel them for the weight loss, because if they want something they have to do something. So for weight loss, they have to do rigorous exercises, and they should keep an eye on their food each and every meal. And as you said, that 500 calorie deficient food should be taken. It is a standard. And medicines, I would like also I would like my inositols and
You give both metformin and minestrone?
yes, both metformin and minestrone.
Any evidence which suggests to give both metformin and inositols?
Yes, PCO patients, they have the mechanism is it's in the inositol level as well as in the insulin sensitization. The level is for both. I would like to give both, but usually I give separately, not the combination level.
Okay. So as we said, how much time we are going to give the patient. This patient, our patient was BMI 37.5. Okay. So she is BMI more than 35. When we have BMI more than 35, the treatment should be deferred till she is BMI less than 35. When in those patients which we have more time, like the young patients, we have more time, we can wait for them to lose weight till they come to be BMI less than 35. Okay, because PCOS resistant fat, they cannot lose fat very easily. So we can add certain medicines to lose weight, which is orlistat, which we can give. Orlistat, while orlistat may be helpful in treatment of obesity, its effectiveness in controlling the metabolic aspect of PCOS is disputed, but still we can try with orlistat, because it will give the motivation for the patients to, if the patient lose 1 or 2 kg of weight also, she will have the motivation to lose more weight. Other medicines like GLP-1 analog, semaglutide, liraglutide. Semaglutide, liraglutide, they are usually provides a very good weight loss, but the compliance is very low due to intolerance. And the SGLT2 inhibitors, these are very good weight loss medicines in cases of PCOS, where dapagliflozin and empagliflozin, Jardiance works very good. And regarding surgery, as I mentioned, if the patient is having the BMI 35 or higher, and is not able to lose weight even after 6 months, then we may advise a surgery, bariatric surgery. There are different types of bariatric surgery, less invasive and more invasive ones. We are not going in details about that. But if the BMI is between 30 and 35 with other associated conditions of PCOS like heart disease or diabetes, high BP, OSA, that is obstructive sleep apnea, then we can advise her a bariatric surgery to lose weight. And then we, when she loses weight, she will have her ovulation, she will have her metabolic correction, and she will have her pregnancy. We'll wait for spontaneous pregnancy. If not, we will go for other modes of treatment for her.
Pratibha, I want to add something, that intermittent fasting is a newer, but this really works. Intermittent fasting, because the drugs which causes the weight loss drug, orlistat and all, this has lots of side effects.
See, this treating PCOS is a multidisciplinary approach. Here, only gynecologists cannot motivate the patient to lose weight. We do need counselors, we do need dietitians and nutritionists along with us to treat the patient. So it's them who will counsel the patient regarding their diet, their nutrition, their mode by which they are going to lose weight. So definitely we'll have a multidisciplinary approach with these kinds of patients.
Yes.
Now, for ovulation induction, what is the first line of management? Dr. Deepak Sharma, would you like to please answer this question?
Thank you, Pratibha, Anisha. Thank you for asking me to something about the ovulation induction. So first line is it is clomiphene citrate or letrozole. In normal case, if there is no signs of hyperandrogenism or hyperinsulinemia and there is no BMI, then you can directly go for clomiphene citrate. And if there is clomiphene citrate plus antagonist, we can give clomiphene citrate plus gonadotropin we can use. This fixed protocol and sometimes intermittent and sequential. So, for CC on letrozole we can give around 52. CC is 50 to 100. And letrozole is 2.5 or 5. We can start BD for 3 to 7 days, and then we can give gonadotropin for say 3rd and 7th day.
The first line of management, Deepak, Dr. Deepak.
First line is management is the directly.
So what is the advantage of letrozole over CC?
If we can use letrozole, there is a effect of hyperestrogenism is not there, because in case of CC, hyperestrogenism is there, and there is also a low of premature luteinization also. So in this case, and letrozole is very much low dose also required, 2.5 or 5 milligram, and it is a monofollicular is another advantage, and we can use nicely in, and there is no requirement of folliculometry also. So in this, I think letrozole is very much effective and convenient over CC in case of first line management of PCOS.
Yes, you rightly said, because it does not have any detrimental effects on endometrium and cervical mucus.
Yes.
Then we may go for timed intercourse also, rather than going for IUI, as you said, that follicular monitoring is not required because they have less chances of multifollicular development. Because with CC, we know that it has a negative effect on the endometrium thickness, and it has chances of multifollicular development. So without follicular monitoring also, we may advise patient to go for timed intercourse with the letrozole cycles. Thank you so much.
Thank you.
So starting dose, as you said, Dr. Deepak, that 2.5 milligram.
Yes, 2.5 milligram.
Not twice daily.
BD, 2.5 milligram BD can give.
And what is the maximum dose you can give?
In CC, you can give about 150.
I'm talking about letrozole.
Letrozole, we can give 2.5 to 5, or in case of, we can use sequentially also. In double the dose, you can give 5 milligram BD or like this.
Yeah, so the maximum effect we get at 2.5 milligram, it may be given as much as high as 12.5 milligram, but the maximum effect we get at 7.5 milligram. So next question is for Dr. Mukesh Fogla. You started with letrozole. You did not get any dominant follicle on day 14. So what are you going to do in this case?
Same cycle.
Same cycle.
Same cycle.
Yeah.
The first cycle of stimulation.
Yes, yes, yes.
Then I'll cancel the cycle and just ask the patient that there is a possibility that there may be a late development of follicle. Just try and come next month on day 2. I'll not add anything. If it is a first cycle, then I will not do anything more. I'll just cancel the cycle.
You are saying that there is possibility of late development, then
that is always there.
Or you will cancel the cycle then and there?
I will cancel the cycle in the sense I will not call her for any more folliculometry, but I'll give them a possibility that there is a chance of late development of follicle. So they should keep a positive eye, and that they keep trying. And if they have a period, then come on second day again for next stimulation.
So in the next cycle, how are you going to proceed?
If I have given the 2.5, next cycle I'll give maybe 5 milligram for 5 days. I'll increase the dose.
Try like this. Second cycle also, she did not have a dominant follicle.
Then there must be some reason. Then she's a resistant PCOD. The drugs are not working.
So what are you going to do next?
When we evaluate why the drug is not working, either she is very obese, or she is having high severe degree of harm.
So you will level her second cycle itself?
No, after 3 cycles, we label her as resistant PCOD. After 3 cycles of failure. Then next, after 3 cycles fail, then we'll think about gonadotropins or losing weight or whatever the cause may be.
Dr. Kanchan, how are you going to proceed in this case?
Well, see, I don't cancel the cycle so easily. What I do is, suppose I starting dose is always 2.5. So I will call the patient on day 9, do a scan. If no follicle is coming up, say up to day 14, then I always follow the step-up protocol. Like in that same cycle, just to save time for the patient. Now they are traveling from so far also. So just to save time for the patient, I start in the same cycle, I double the dose. Okay. So like suppose I was starting with 2.5, then I will make it 5, one tap twice daily. Okay, again after a week I do a scan for 5 days, and again after a week I do a scan and see. Maximum till 7.5. If till 7.5, after that also if she's not developing any follicle, then for that cycle, okay, fine. I just don't try anymore. Then on the subsequent cycle, I start both with the letrozole as well as gonadotropins. Combination, I give a combination. If the patient is not responding to letrozole oral drug, even after the maximum dose, I will start a combination in the subsequent cycle. The letrozole as well as the gonadotropin. There are many other protocols also. You can do a step-up protocol, which works actually very well. I have been giving this to my resistant patients, and I'm getting a very good result where I'm giving 1 tablet on day 2, then 2 tab on day 3, 3 tab on day 4, and 4 tab on day 6. Like total 10 tablets only, but I'm using a step-up protocol, and then we can call the patient. If the patient is not developing, there is an extended protocol also. So actually, there are many protocols which we can try for the patient before labeling the patient as resistant. This is what I'm doing.
Yes, we can try.
We can extended protocol also where we give 1 tablet daily for 10 days. That also can be done.
Yeah, there are many evidence-based protocols which we can try. Maximum, how many cycles can we try for this ovulation induction?
If whether the patient is ovulating or not, if the patient is ovulating and still not conceiving, so see, if I always, I always plan for the patient. If first, supposedly I'm starting only with the time coitus, then 3 cycles I give to the patient. After that also, if she's not conceiving, then I do IUI also. That again also 3 to 4 cycles. Not more than 6 cycles I'm not giving. And as per the guidelines also, not more than 12 cycles we should not give. So, but me, I'm okay. If I am doing the case and 6 cycles, if the patient is not responding to my treatment, then I think something else, like suppose maybe IVF or something.
Dr. Devanjana, in this case, if you want to switch over to CC, so what would be your starting dose with clomiphene citrate and your maximum dose? Can you hear me, Dr. Devanjana? Are you there? Dr. Shweta, would you like to answer this question?
Yeah. If I take CC, then my starting dose will be 50 milligram, and that I can start on any day 2, 3, 4. And for 5 days, I'm giving here. We can go to a maximum of theoretically 250, but it is said that the effect, if it is seen, then it will be seen by 150 only. So I think by maximum, I'll go till 150 milligram only.
Yeah, very true. 50, 100, 150 milligram. We can go up to 250, but evidence says 150 milligram gives the maximum results.
Right.
And when to stop with clomiphene?
Pardon?
When you have started with clomiphene, you have tried 1 cycle, patient is not ovulating, you have tried another cycle. So how many cycles would you like to try with clomiphene?
Yeah, it's like maximum 6 cycles only we can try. And suppose if she doesn't ovulate, then we can label that patient as clomiphene failure.
Yeah. So maximum 6 cycles. And also one evidence, one meta-analysis, it said that if endometrial thickness is less than 7 millimeter at ovulation, then also we can switch over to another protocol. When there is, why there is no response with CC? Because of its anti-estrogenic effects on the cervical mucus and the endometrium lining. Dr. Jury, if the endometrium thickness on day 12 is 6.1, would you like to add estrogen?
No, not on day 12. I would like to add estrogen later. On day 12, if the follicle, I will first I will see if the endometrium is corresponding with the follicular growth. If the follicle is also not growing, endometrium thickness may be 6.1 on day 12. So
16 mm.
Follicle is 16 mm.
Yeah.
Follicle is 16 mm on day 12 and endometrium is 6.1. So I'll wait for a few days. I would like to add Ecosprin, aspirin, and then sildenafil, but not estrogen on day 12.
So will sildenafil and aspirin would increase the endometrial thickness in these patients?
Yes, it may help. And also L-arginine. It helps. I would like to add estrogen after ovulation.
Evidence says that there is no role of adding estrogen in these cases because we have seen prescriptions that when the estrogen is less, we are calling the patient on day 9, day 11, we see that the endometrium is not matching. In CC, the endometrium will not match with the endometrial thickness will not match with the follicle. So we know the anti-estrogenic effect of, so we are not to add estrogen in these cycles. Okay. What would be your targeted number of follicles? Dr. Sumita Gogoi?
Sorry, you're talking about the number of follicles or the size of follicles?
Number of follicles, like when will you stop or cancel the cycle when you see the number of follicles are more, or how many follicles
of developed follicles?
So yeah, the number I would, the goal of any induction would be definitely a monofollicular development. 3 or more follicles, we are definitely not going ahead.
Yes. 3 or more follicles, if they are present, we are not going ahead with the cycle.
Yes.
What would be your targeted follicle size for sugar?
Anything more than 18 millimeter.
So evidence says that it is better if we go for 21 to 22 mm size. And also it depends on the vascularity of the follicle. The PSV, if it is more than 10, then it is good for ovulation.
Yes.
So, Dr. Mukesh, would you like to combine letrozole and CC together in any cycles?
I never tried. No, not tried.
So yeah, why have I put this question? Because newer evidences are coming up where people are adding letrozole and CC together, and many meta-analysis researches are being done for this. And maybe in near future, we are going to have a article or a meta-analysis with this, where we have letrozole and CC together protocols for ovulation induction in PCOS cases. So which one is better, CC or letrozole? So we know that either CC or letrozole gives good results, equal results. It's totally depend on the patient profile and also our personal experience. And obviously letrozole is superior than CC. We know that in case of PCOS. Now, when to add gonadotropins? Dr. Devanjana, are you able to hear us now? Dr. Devanjana? Okay, Dr. Deepak Sharma, would you like to add your views on this?
If we do not get the proper development of follicle by CC or letrozole, then we can go for gonadotropin. And in certain cases, if the patient has oligomenorrhea and signs of hyperandrogenism and hyperinsulinemia, and in that case also we go for gonadotropin. Because in that case we need control ovarian control stimulation, and it is better to go for recombinant FSH, or we can go for HMG also. If the LH level is less, then we can go for HMG. If the LH level is more, then we can go for HMG, FSH. And dose is Now, what is, I think it is better to go for step up protocol. And so, along with gonadotropin, we can add CC also, antagonist also. And so it depends upon the actual severity of the, as you have told, severity of the PCOS. If the patient is more severe, and then we go for the gonadotropin, and along with the agonist or antagonist. And but nowadays, most of the cases we use the antagonist plus gonadotropin. And those, if we go for those, then
Is the ovulation induction you're going to is antagonist?
yes. If the patient is, now if the patient is severe, then we go for a antagonist. That means it depends upon the level of the, as you told me, this day 3 FSH, LH, and estradiol. If the LH is high and patient is not proper responding with the other ovulatory induction drug, then we go for gonadotropin. And those actually depend upon the age also, AFC count also, AMH. If the AMH is low and age is high, then according to actually age, if the age is more, then dose is a bit higher. Sometimes it is 175 to 150. It is sometimes it is 300 also. And if the AMH level is low, then we go for also higher doses. And if LH is less than 12, then we go for lesser amount of gonadotropin and antagonist. If we go, if his LH is more than 12, then we go for the agonist or antagonist cycle. So I think this is the dose, and in that type of cases, we go for gonadotropin. And along with, if she has other problem also, we have to treat. If it is has hypothyroidism, and we have to give that antithyroid drug. If it is hyperprolactinemia, then we have to treat the hyperprolactinemia. And if she had hyperinsulinemia, then we go for insulin sensitized agent like metformin.
About gonadotropins right now.
Yes.
So to answer the when to add gonadotropins, so there are different protocols, like when this is a letrozole resistance or clomiphene resistance. We have seen the previous cycles, they did not respond to the first line of management. Then gonadotropin is the second line of management. We combine with any of the drug. And then this is a actually tailor-made for different patient profiles, which we see, we can evaluate with our previous cycles. Then which gonadotropin, evidence always says recombinant FSH, but because of the cost factor and everything, we may go for any other like HMG and all, but evidence always says it's recombinant FSH. And those we have 3 protocols, that is the low dose, the step up and step down. And it again depends on the patient profile, which we are going to use. Any other medicines you would like to add? The question now goes to Dr. Jury Khanikar.
Yes, for PCO or which patient? This
same patient.
Not responding to CC. Which patient?
Patient 29 years, married for 2 years, amenorrhea 2 months, BMI 37.5. So
yes, definitely.
Would you like to add any adjuvant for them?
Yes, I would like to add metformin and myo-inositol.
As you said, you will add both. Dr.
Yes.
Kanchana, your views, what would you like to add?
Yeah, since the BMI is also more, this patient usually has insulin resistance in the body. So definitely I would like to add only metformin is good enough. Because combination, as per the evidences, don't speak about that the combination is better.
No, I don't give combination drug, but I give separately.
Okay.
A combination drug I don't prefer, I give separately.
Okay. So from my side, I would like I would like to add only metformin. And we can, in PCOS patient, what we have seen that vitamin D is usually very low. So
Yes.
if her vitamin D is low, then I would like to add vitamin D for this patient. And during ovulation induction, sometimes we give dexamethasone also to suppress the androgen levels. So that's all from my side.
So metformin is the first choice of drug for insulin sensitization, and evidence says when there are more research to be done on myonistal, which would say that myonistal is preferred over metformin. So myonistal till date, it is said that those patients who don't tolerate metformin for their GI intolerance, in those cases we may add myonistal. Secondly, you said about vitamin D, rightly said, because vitamin D is associated with reduction in ovulation rate, pregnancy rate, and the chances of live delivery in PCOS women receiving ovarian stimulation. And metformin is the choice of drug. And regarding ionstol and metformin, both gives the same result, apart from their side effects, where those patients don't tolerate metformin, we would like to go with myonistal. Regarding steroid, it is said that steroid usually not preferred because of it causing a gain in the weight, and it is only to be used in patients with CH, congenital adrenal hyperplasia patients with PCOS. Okay, so laparoscopic ovarian drilling. Anyone in the forum who would go for laparoscopic ovarian drilling? Anyone of the panelists?
Dr. Pratibha, it is actually indicated if there is any other associated cause of infertility. That means if it is associated with tubal factor, or if it is associated with the other that is fibroid and like this, and then we can directly go for LOD because it has a role. And number two is if the patient is clomiphene resistant, besides gonadotropin, we can go for LOD also, though it is not advisable. But in some cases, we can give if it is done in proper manner, then we can go we can get the good result, because it is in compared to other in comparison to other agents, the LOD is less expensive. And it is one time, but we can avoid the whatever the complication occur because of the surgery. We can advise if we do properly.
I would like to add here, like as sir told, that's very true. The present day indication for LOD is yes, whenever we are putting the patient for laparoscopy, then at the same sitting we can do it. But we also need to see that in which patients this LOD is going to work better. So like we know the prognostic factors are in young patients, the LH level high, that means lean PCOS, LH level is high. And so in those cases, we'll get better results for LOD as compared to the OBs and like high low LH patients.
Here, I would like to mention one thing that we have our experts, Dr. Sneha, Dr. Rekha, and Dr. Bharati with us. So anytime you feel, welcome ma'am, anytime you feel that you need to give your expert opinion, you are most welcome to share your valuable ideas in this forum. So regarding LOD, the recent evidence which says it's not advisable, even if you are going for laparoscopy for other causes, because it have many other complications than doing good for the patient. Michelle, can you please?
So this is our third case. She has presented with infertility for 2 years. She's a diagnosed case of PCOS and her husband's sperm parameters are normal. Started on ovulation
already
induction.
Answered this. Dr. Sumita has already answered this. Now we'll go with another case. So yeah.
The lean PCOS one.
Dr. Sumita has already answered this, that more than 3 follicles, we are going to cancel this. Now we take another case. How much time do we have now? The MOCs, how much time left for us? Okay, we go ahead with this case.
Hello, I think another 10 minutes.
Okay, we take this case.
This will be our last case then. So she's a 31-year-old girl. So this time we have a different scenario. Till now we were dealing with women with all obese PCOS. This time her BMI is 21.3. So she's a lean PCOS. Her semen parameters are almost normal. And her hormone parameters are FSH is 6, LH is 13. We can see here LH is on the highest side. Thyroid prolactin were on the normal side. And clinically, she had history of irregular cycles for last 4 years. Then she had acne, hirsutism, everything was present. And she was full-blown a PCOD case in ultrasound as well. So how will we like to proceed in this patient? Dr. Devanjana, ma'am, are you there with us?
I think she lost her connection. She's not there.
Dr. Sumita, ma'am, are you still there with us?
Yes.
Ma'am, how will you like to manage this patient? She's a case of lean PCOS.
So yeah, a lean PCOS with definitely a high LH, and AMH I'm reading is also very high, with features of hyperandrogenism. So this, in whatever we do, we have to keep in mind that these cases are very prone to OHSs. So whatever, that should always be in the back of our mind. And I would first, since all the investigations have already been done, I would first like to put her on OCP to regularize her cycle. Then we might add metformin to this, because this will help in correcting her metabolic parameters. And after that, I think we would maybe 3 months of OCPs and metformin. We would like to put this patient on a low dose ovulation stimulation for ovulation induction, starting with low dose letrozole.
So the patient is 31 years old, married for 7 years. And what counseling will you give when you advise her OCPs? Because patient has come to you for pregnancy and you are advising her OCPs.
So definitely, I think we should tell her that this is the OCP would be a way of managing her disease process and not just contraception. So we have to counsel her on that regard.
So Dr. Mukesh, sir, would you like to proceed in the same way?
Tubal patency, has it been done? Tubal patency, tubes are patent?
No, it has not been done. We would like to do it.
Yeah, tubal patency should be done first. And I would like to know the treatment history, because she's married for 7 years. She must have taken some treatment earlier. No? So it is the earlier treatment history is very important. How many cycles of ovulation induction she has undergone, and whether she was given any gonadotropins. Prima facie, she looks like a case for a IVF.
Would you straightforward go? She has come to clinic for the very first time.
No, she's coming for the first time.
Yes.
No previous treatments taken.
No previous treatment taken. She is a lady from
I'll do tubal patency. I'll do a tubal patency, and basically I'll go for stimulation with letrozole straight away. 5 milligram of letrozole. I'll give a slightly higher dose, because it looks like a resistant PCOD.
Would you like down regulation as mentioned by Dr. Sumita Gogoi?
No, I'm not very much in favor of giving OC pills.
Okay, without down regulation, you're going to proceed with letrozole.
I have letrozole.
Okay. Any other adjuvant?
Not taken any treatment earlier. Then I'll first thing I'll do is give her letrozole for 5 days. And see her. Yeah.
Any adjuvant?
No adjuvant.
So here, because she has acne hirsutism, that indicates that she definitely has insulin resistance, features of hyperandrogenism. So in this case, metformin, the insulin sensitizers, I think should be added with AMH 13. The insulin sensitizers need to be added.
Definitely.
Would someone like to add anything else in this case? Any of the panelists?
So if the patient is in distress with the hirsutism, if
go
we
for
start
dexamethasone also, if it is. I think there is only option metformin and
Metformin, yeah.
Metformin, myoinositol.
Yes.
Directly go for it is I think this weight is, but it is this T condition is there. LH is high.
There is one molecule which has come out, and I don't know the efficacy of it. We have a very odd random studies here, and there is one more molecule which has come, and I don't know the efficacy, but N-acetylcysteine.
This is not evidently
Yes.
proved.
It's not evidence-based. It's not
Meta-analysis with that molecule.
Yes.
It's not evidence-based.
Yes.
So we're not talking about N-acetylcysteine here. So definitely, like in this patient, we are going to adjuvant with metformin for insulin sensitization, and also we would have a multidisciplinary approach in this case also with a dermatologist treating her acne, hirsutism, giving her medicines for that. And how many cycles would you try with ovulation induction in this case? Kanika?
Yes. Hello.
How many cycles of ovulation induction would you try in this case?
Ovulation induction and naturally, naturally. I would like to, she is married for 7 years, infertility for 7 years and 31 years. So I would like to give her 2 to 3 months for to try naturally with along with the medications. And after that, after 2 months of myoinositol and metformin, I'll start her ovulation induction with letrozole for 1 or 2 cycles, and then I'll straight away go for letrozole and gonadotropins, and then IUI, and step by step I will offer her IVF.
Dr. Kanchan, this patient did her tubal patency, and we found one-sided tube block. Now, how do you manage this patient?
Okay, yeah. So if one cycle is, can you hear me?
Yes.
There's a network issue going on. Can you hear me?
Yes, we hear you.
So see, even if one tube is blocked, the patient can still conceive if the other tube is patent. Okay. So, but since the duration of infertility is 7 years, which is a pretty long period, so I would like to, I will not tell her to try naturally. We will straight away, I think I'll go ahead with IUI only. And if the patient 3 cycles is not conceiving, then because the age is also 31 years, so then I will advise her to go ahead with IVF.
For 3 cycles, going for 3 cycles, that means we are using 6 months of her life for trying for pregnancy with IUI, right?
Only 3 cycles, I'm saying, not 6 months. 3 months. 3 months I'll try with IUI.
She has one-sided patent. So it will definitely have to be alternate cycles you'll try for IUI, right?
No. It's not like that. It's not like that. Even if one tube is patent, even if the ovulation is happening from the other side, the tube just goes and pick up the egg. It's not which side is patent and that side only the follicle will develop and the tube will pick. It's not like that. The physiology doesn't work like that.
It may develop from both sides also.
If time permit, can we take this question? A 35 years old, married for 8 years, BMI 26.4, presenting with infertility, AMH 11.7, normal semen parameters, undergone 3 cycles of IUI, 1 IVF, where she has moderate OHSS. She has come to you. How do you proceed? The question now goes to Dr. Jury.
Patient had moderate OHSS in her previous cycle. So I'll offer her, I'll ask her to go for IVF, but pre-IVF, before IVF, I'll give her metformin, and her BMI is 26.4. I'll ask her to change her lifestyle, diet, and exercises, and then I'll go for IVF. That's all.
Dr. Mukesh? What precautions
you mean
are you
how will I proceed with the next cycle of IVF?
Yeah, what precautions are you going to take in the next cycle?
I'm going to do an antagonist cycle with all freeze embryos and transfer it in the next cycle.
Yes. Number 1, intake cycles. Number 2, frozen embryo transfers. right? Because if you go for fresh embryo transfers, she always has a chance for OHSS, and to decrease OHSS, we always go for frozen embryo transfers. Okay, so I think we had a good discussion here. We have our experts. Would you like to comment? Anything from our expert side, Dr. Sneha, Dr. Rekha, Dr. Bharti? So we learned about the case when she comes to us. We first go for the evaluation, proper evaluation. PCOS is mostly obese PCOS. We go for weight reduction, that is 5 to 10% of her body weight. We give drugs for ovulation induction, maybe clomiphene or letrozole. Then second line, we go for gonadotropin. Then laparoscopic ovarian drilling not advised. Metformin versus minestrol, always metformin. Then steroid not advisable. So these were the take-home points we had taken from this panel discussion. So one point from each of you regarding this PCOS, what would you like to advise to your patient? Dr. Mukesh?
Regarding what?
Regarding a patient with PCOS has come to you, what piece of advice, a most important piece of advice would you give to her?
Diet and exercise.
Dr. Kanchan?
My only advice is lifestyle modification, maintain a this ideal BMI. That is my only advice to all my PCOS patients, whether a young girl is coming or a married woman or for infertility or whatever. This is my advice to them. Just maintain a good BMI, diet and exercise.
So PCOS patients will always be patients. So most important thing I would advise is not just from the fertility point of view, but also lifestyle. These patients are more prone to dyslipidemia, coronary artery disease, diabetes mellitus, endometrial cancer, so on and so forth. So these patients require counseling for long-term treatment and follow-up. Follow-up is very important, and we should not look at the patients only from fertility point of view, but also as counsel them to have a long and healthy life. So
Yes.
for that checking their lipid profiles, fasting glucose levels, and checking their weight, and so on. These points are very important. So I think we should look at them not just from fertility point of view, and because as most of us are practicing fertility, and so they come to you just for fertility, but it's a good point of contact where we can also advise them for lifestyle changes and weight management and long-term treatment for other metabolic diseases as well.
Yes, so we go with the multidisciplinary approach in these patients.
Yes.
Dr. Jury, a piece of advice to your patient with PCOS?
Yes, PCOS is a disorder. It is not a disease. So I will just advise them to go I'll inform them what may be happen, what are the complications may have if they do not take care of themselves. So I would like to ask them to adopt a healthy lifestyle every day.
Okay. Dr. Shweta?
Normally what I do is I encourage my obese PCOS patient by saying that you look beautiful that way also, but if you reduce your weight, you will look more beautiful. So they really have a beautiful smile on that. And I think it really works if we properly counsel them regarding the benefits. So that's me. Pratibha, I would really like to request our expert to throw some light on this LOT part, because what I have read the guidelines was like, these were the parameters on which we can really go for which are the indicated cases for laparoscopic ovarian drilling. So if our experts can give valuable opinion on that.
Yeah, let me first finish with Dr. Deepak.
Yeah, sure.
Advice first.
So if any patient come to PCOS, two things we have to, first is the early diagnosis, where it is PCOS, and number two, we have to prevent the far-reaching complication, that means metabolic syndrome. So to overcome this complication, we have to advise the diet, diet and exercise, and lifestyle intervention. And
please say PCOS is always diet, lifestyle modification, and very
if-
hard to treat.
If she has also signs of hyperandrogenism and hyper, we can go for insulin sensitization directly also. There is no harm actually in myoinositol also or metformin also we can use. But we have to proper counseling the patient for the complication. That means any type 2 diabetes, hypertension, endometrial CA, whatever you told in the first slide. So that is more important. We have to prevent the far-reaching complications. What is the you can say the not complication is the sequelae of the PCOS. If any lady we have developed PCOS, so she is waiting for the other complication, that is type 2 diabetes mellitus, hypertension, cardiovascular accident. So it is always better to counsel her. So if you do not maintain your weight and exercise and diet, then you may end up ultimately those complications which are more which are causing more harm in her life.
Definitely, we have to counsel them about the late complications of
Late
PCOS, so
metabolic
that they really start working on it at that time since then. And with my personal experience, what I have seen that the GI tolerance of metformin increases when I prescribe her metformin and say that this is the medicine which is going to lose your weight. So though it is not evidence-based, but when we say that this medicine will also lose your weight, then they take it very happily and there is no gastric intolerance in those patients. That was just a personal experience from my side. And now I would really like our experts to throw some view. Dr. Sneha, Dr. Rekha, Dr. Bharti, anyone? If not, we would like our MOCs to take over the forum. I will stop sharing my screen.
So big round of applause for two learned moderator, Pratibha Madam and Isa Goel Madam, and all the panelists making this panel very interesting. With PCOS and induction as a very complex subject, but to make it easy and with good carry homes, this panel is made very interesting.
Thank you
Yes,
so much.
yes, thank you.
So
Welcome.
I thank all our panelists for their expert views on PCOS. Thank you so much.
Thank you and good night.
Thank you.
Thank you, Dr. Burger. Thank you, MC Patel, sir.
Thank
you
you.
very much for
MC
having
sir.
us here.
Yes, Mukesh,
MC
Deepak,
Thank you.
and
Thank you, sir.
Kanchan Madam, Sweta Madam, so many.
Thank you, sir. Thank you for having us with you. It was great, sir. Thank you so much.
Welcome.
Thank you so much, and your insights on ART, like really appreciable, sir. Thank you so much. For that.
These are the real situation which have happened in past, and few of our friends have faced in court of law. So all the situations I mentioned, real cases.
Yes, sir.
Nice elaboration.
Yes, yes, Deepak.
So I think we are done with this
Oh, yes.
meeting.
Oh, yes. Asa or Kalpana?
Yes, sir.
Yes.
Yes, sir. Thank you, sir.
We can conclude.
Thank you, sir. So I thank all the faculty and all the listeners who have been here in this program, and a great effort by the moderators and these new panelists. You're looking so young and you have so much to teach. So it's been really fun listening to all of you and a great learning experience. Thank you, MC sir, for putting such a program together and finding the talents of every part of the country. So hats off to you. I don't know how you do it, but you really have top talents everywhere.
Yes.
And your talk today was also very outstanding. So no words to say for all the talks and this whole program. Thanks a lot, everyone who has joined in. Thanks a lot, Corona Remedies, for being for facilitating this program. And thank you, dear listeners who have made this program useful. Thanks a lot. Namaskar. Good night.
Thank you.
Thank you, ma'am.
Asha, as such, North is close to my heart because I don't know from this faculty how much they know. Since 20 years, 20 years, we visit Northeast once in a year for medical camps for one week. This year I was at Haflong district and very remote places of border of Assam near Nagaland. Last year I had been to Dibrugarh district. I had a phone call to Mukesh also, if Mukesh can recollect. So that way, and in the return journey, I had been to Sivsagar, Dr. Barua. So for Northeast, to narrate all these societies' name, etc., it is very easy for me because I know all of them personally.
No, sir, actually, all over the country, we've been through so many webinars.
Yes.
Always, it has not been just somebody's prepared slides, somebody's presenting.
no,
It has
no.
always been
Yes.
original,
Yes.
and it is so good.
Yes.
It's very good. Thanks a lot for having us join in and be part of it.
Yes.
Thanks a lot.
Good. So thank you all the societies of
Thank
Assam
you.
who have joined this.
Thank you so much, sir. Thank you.
Okay. We can
From
conclude.
ending the session.
Oh yes, we can conclude.
Thank